I think it's 5. We'll start our webinar. I hope everybody can hear
Hi,
me. Hi.
this is Peter Schulman, Germany.
So, welcome everybody to the Pan Ophthalmologica 2025. This World Sight Day, we'll start our presentation right away. The first presentation would be I would want to welcome Dr. Raj K. Mathuri. He's a highly accomplished vitreoretinal surgeon and clinical associate professor at the Indiana University School of Medicine. He completed his medical degree with honors from New York University and went on to pursue his residency in ophthalmology at Baylor College of Medicine, followed by a fellowship in vitreoretinal diseases and surgery at the prestigious University of Iowa. He currently practices at Retina Partners Midwest, where his expertise span a wide range of retinal conditions, including diabetic retinopathy, macular degeneration, retinal detachment, and genetic retinal disorders. He's also actively involved in numerous clinical trials focused on diabetic retinopathy, ARMD, uveitis, retinal vascular occlusion, and he also serves as a reviewer for several leading ophthalmology journals, including Ophthalmology, Archives of Ophthalmology, and we are honored to have you here, sir. Uh, it's your it's your pitch, sir.
Hello.
Thank you. Yeah.
Thank you, Prithvi, for that introduction. Very generous. I'd like to talk about something that maybe something we should be doing more often. And I've been doing this more often the last few years. And we actually started a study in the DRCR. How about vitrectomy in early PDR cases? In those cases, there is no vitreous hemorrhage. What does this mean? This is, for example, a case of moderate PDR in a patient with a small amount of NVE. And normally you could treat this very much in the clinic, but using small gauge vitrectomy and absolutely insisting on using triamcinolone to find any adhesions of the vitreous to the retina, uh, inducing a PVD and removing as much vitreous as possible, because really the vitreous is the culprit in all of these cases. I think if we do this, and what I do is do an extremely generous PRP, as you'll see in this case, where I go all the way to the pars plana and come at least to the equator. The second thing I do is I make sure I look at a fluorescein angiogram of an optos and kind of endolaser any part that looks severely ischemic or non-perfused. Generally, those are the poorly the patient already has lost visual field in those areas. So treating that area doesn't do anything but decrease the amount of VEGF that's produced. I always generally leave a tiny amount of triamcinolone in the eye at the case. So the reason for doing all of these things in an early manner is so that we can prevent the stuff that we all end up dealing with. And at this point, I think if we have a patient of ours that we end up doing something like this, where we have to peel severe traction using vertical scissors, doing all of these things for 2 hours to get a 2400 vision, I think even though we can improve these cases, I do them all day. I've been doing them for 25 years. We get a result like this, but it's just not there. It's not good enough for us. I think we have to get to this early. And that's the whole goal. Why does this matter? 36 million people in the US have diabetes, of which 10 million people have diabetic retinopathy. And this graph is based on just 2-year-old data, where vision-threatening diabetic retinopathy is 1.8 million, 1.2 million have PDR, 0.4 million have both. So in the US alone, 1.6 million have significant diabetic retinopathy that can cause vision loss. What are we doing currently? We're doing Clarity or Protocol S-based treatment, where anti-VEGF and PRP are shown to be viable treatments. Neither of them are perfectly effective or durable. For example, even with PRP, 50% of eyes with full PRP will need additional treatment for neovascularization, recurrence, or vitreous hemorrhage. And Protocol S data, 5 years, we have good long-term data, and we find that 46% still develop vitreous hemorrhage, 12% traction detachment, almost 20% undergo PRP, PPV anyway. And then 5-year outcomes show that while PRP laser is useful, it is not the end-all and be-all. This is an excellent slide from Maria Barakol, which shows severe traction developing even in a patient with 2,000 spots of PRP. How about anti-VEGF? This is the one take-home slide I always think about when I see a patient who's been treated only with anti-VEGF or PDR. If you have DME, like we treated in Protocol I over 5 years, by the end of the 5th year, the number of injections a patient needs for DME is 0. However, if they have PDR, they need a bunch of injections all the way through. And that need does not stop at 5 years, it doesn't stop at 15 years, it doesn't stop ever. And the biggest issue we have with our patients is patients not coming back. Yes, we all have 10, 20% of patients who will be very religious and come do their part. But a vast majority of diabetics have so many other concomitant diseases that many times, through no fault of their own, they miss follow-up and have severe DR complications. So just to make this something real, we started a study in the DRCR where almost 400 sites are present as part of the DRCR, and we're getting sites enrolling all the time. And I wanted to share this protocol with you. So maybe one, people on this call could consider joining the protocol, or two, see that it's actually a viable system and do it on their own and decrease the risk of vision loss. After all, we're doing all of this on World Sight Day. The two arms to the study. The first one is faricimab plus PRP, where many clinicians are using a combination therapy, but there's no real good long-term data on visual acuity outcomes in this approach. The second is vitrectomy with endolaser, where I've showed you on the video, early vitrectomy, full PRP, removing all of the hyaloid, which I believe is the main contributor to PDR bursting and development of traction detachment. And always using small gauge 25, 27 gauge, always using triamcinolone to see what's happening. One of the things that I think this data, which will be presented in a few years, will show how this works in a long randomized trial. And I wanted to show you what they are. The trial is actually quite straightforward. You're taking patients with moderate PDR or worse. I'll show you what this means on current imaging modalities as opposed to the old 7 field. No traction detachment of the macula, no significant hemorrhage, and just one-to-one randomizing them to immediate PRP or with faricimab or immediate PPV. And we're looking at the primary outcome, which is change in visual acuity from baseline to 3 years, and the number of additional treatments the patient would need over the 3-year period after the initial treatment. Another thing we're looking at is what happens to traction detachments, macular-threatening traction detachment, change in visual acuity under curve, the number of visits over 3 years, all of the other procedures that are generally needed for these patients. We're looking at patients with relatively good vision, no significant VMT. And then this is kind of how the Wisconsin Reading Center has worked with us to come up with what defines PDR that's worthwhile with treatment. We take the original 7 grids, as you can see outlined, and then add extensions to them and call them peripheral field 3, 5, 7, 1. And each of these extensions essentially accounted with the original grid. So DRSS level 65 on fundus photography is defined by neovascularization within this grid. However, if there's neovascularization in the periphery, it still counts as if it is within the grid. So it's extending the countering area larger. And we also acknowledge that both NVD and NVE would be best seen in ultra-wide field fluorescein angiography, so we can use that as well. So what is level 65 or moderate PDR? Any NVD, as you can see here, as well as an area of preretinal hemorrhage. Any NVD counts as moderate PDR. Any NVE greater than a quarter to half disc area. In this case, we use the sum total of all NVE greater than half disc area with a little bit of hemorrhage. How about exclusion? We don't want anybody with significant hemorrhage that precludes a PRP, severe traction on the macula, or foveal vitreomacular traction like this, or edema, because both of these things would kind of obviously make the surgical result look better. We wanted to make it an even field. What's the randomization treatment? And this is what we thought based on the DRCR survey of all of our physicians is how they approach PDR patients with PRP right now. They do an injection of anti-VEGF, sometimes up to 3, and PRP up to 3 sessions, all within 90 days of randomization. So you have a patient with active PDR, within 90 days you finish this. Or on the other hand, you do an injection first before vitrectomy and do the entire procedure all within 4 weeks. And then you do a complete PRP in all of those cases. And we define complete PRP in both of these groups as up to 2,400 burns using an automated pattern. And a vitrectomy with endolaser, we also do a complete PRP, typically using a curved endoprobe or an indirect laser in the operating room, and at least beginning 3,000 microns from the macular center and extending to at least the equator for 12 clock hours, or for the peripheral. The procedures are straightforward, and I'm showing them to you because this is kind of what we do in clinic anyway. The biggest thing is ultra-wide field fundus photos and angiography at screening so that we can get the patient and randomize just the correct patient. And then we do randomization as soon as the reading center confirms, and then imaging is what is followed. So our hope is this: the patients come at week 16, which is about 4 months following the initial treatment. Regardless of which treatment branch they undergo, both ultra-wide field and fundus photography is done here to confirm that the neovascularization is quiescent. And if it is, we watch them. If it's not quiescent, then we treat with additional anti-VEGF plus fill in PRP if there's room. And then we keep doing follow-up in 8 weeks using ultra-wide field photos to make sure that there's regression and quiescence. How about active PDR? It's important to do imaging just so that we can tell what the change in neovascularization is. A fluorescein isn't as useful to talk about regression because a fluorescein will show leakage even from a fibrotic neovascular membrane. A fundus photo is actually more useful. And the treatment is identical for both groups. If there's recurrent vitreous hemorrhage for about 4 months, then additional vitrectomy can be performed in either group. And at this point, we're not including steroid injections because they can confound the results. If they have DME, we are following the basic protocol T algorithm for it. These are some examples of what we think would be useful patients for this study. Peripheral neovascularization, some NVD, a lot of non-perfusion. This is perfect patient to randomize into this study, either vitrectomy or PRP plus anti-VEGF. Another one with a small NVD, as well as preretinal hemorrhage with small tufts of NVE in the periphery. Similarly here, if you count all of the NVE in the peripheral and add up to about a half disc area, so this patient would qualify, you can see the large areas of non-perfusion. These are the things I watch for, especially if there's non-perfusion with late leakage. These are, in my opinion, those eyes are the most likely to advance and therefore most likely to require more and earlier therapy, more aggressive therapy. This is a patient with peripheral NVE and preretinal hemorrhage. Again, this would qualify. I wouldn't put this patient in the study. This patient will probably need surgery, but if the central vision is identical, is excellent, there's no need to do that. Similarly, NVE in the periphery, we would enroll. And what about patients like this? These are the other, the study allows the physician to determine what's non-foveal traction, and that's what this is. And this is my approach in general when there's peripheral traction of this nature, slowly using the cutter face away from the fovea and cutting as much traction off as possible. Again, the goal in my mind is always to remove all of the peripheral traction as much as possible, all of the preretinal hemorrhage as much as possible. And if there's one thing I've taken away from doing this for a long time, it's that we cannot do any sort of, we have to do diathermy in these cases. I think doing endolaser is a quick and easy way to stop the traction, but we cannot do that. We have to do we have to do diathermy to stop the neovascular tufts from being an issue. So that is only the one thing I might suggest we take home. And going slow sometimes when you have blood like this, it's actually remarkably useful because it helps you demarcate what you can cut versus what you cannot cut. This is a case where I was using a 25 gauge instrument, and I have started to use 27 gauge instruments in these cases because the tip of the cutter is much closer to the edge and allows me to get a much better resolution. This is diathermy in about 20% power on the Alcon system, and I really bring the intraocular pressure down to 12 to 15 and look for areas of neovascularization and leakage so I can treat every one of them. That is, I think, important thing that we can all do to allow these patients to get back to good vision sooner than later. And and I'll often put a little bit of air, leave the eye full of air at the end so that there is a higher chance that any small hemorrhages can be treated. So even though there's no need for gas, air is a great tamponade to stop small bleeds. And usually within a week, we have a patient who gets much quicker visual acuity result. And this is doing it at regular speed because I think there's no need to go super fast in these areas. It's important to go just in the right zone and time to get the result we want. And I can forward and then do a full PRP and an air bubble at the end. So that's my take on this. Thank you guys for your time. Happy for taking any questions.
Thank you so much, sir, for your valuable insights. Few questions I was thinking about was, do you also do ILM peeling in cases, especially on those which have hard exudates? Do you combine your cases with ILM peeling?
So that's an excellent question. Some of the recent data shows that PVR recurrence is much lower when you peel the ILM. I have found that to be true. In these cases, if I can get a complete separation of the vitreous base as well as through the macula, and the retina itself at the fovea does not have much edema, then I will not peel ILM. However, if there is any edema, again, those patients wouldn't be part of a study. But if there is good visualization and there is any edema, ILM peeling, I think, might be useful. I don't think vitrectomy alone decreases your risk for any sort of DME recurrence decrease. I think patients who have DME will have DME and leakage with or without vitrectomy. I don't think we improve the rates much. There have been multiple studies talking about it, but in my experience, I don't think it's true.
And also, how many days do you, put the intravitreal injections, faricimab or any anti-VEGF prior surgery? What is the gap of days
Sure.
that you
Maximum of 3 weeks.
do?
If it's going to be longer, then I just have the patient come back the week before injection. I think you get peak benefit about a week out. So you have the most amount of regression as well as the least amount of bleeding during surgery, which is always helpful.
And any other blood investigation that you are very particular about? If the blood sugars are maybe HbA1c, what do you suggest the patient bring their HbA1c to before doing the surgery? Any specific value?
HbA1c will take 90 days to really change, 45 days minimum, because its half-life is so long. So the best thing to do is to get 2 weeks of good sugar control on these patients. I think you start off with something useful. I think 2 weeks of blood sugars under 150. I'm happy to take them to surgery. And sometimes I can't even achieve that. Patients have trouble getting those things correct. That's why they're needing vitrectomy surgery in the first place. So I don't really stop a poor sugar from making sure that they're treated. I think waiting on that can sometimes result in too long a wait and non-compliance. That's my biggest fear with these patients.
And most of my times when I do surgery, I tend to have a few patchy vitreous sheets which you come across, and it doesn't
Mhm.
actually come along with the vitrector. So we need to, slowly scrape it. Do you get those kind of cases too? And what do you do for those kind of cases, sir?
Sure. I think vitreous adhesion can be very segmental, where some areas are far more sticky than others. The most important thing to do, especially for newer surgeons, is to have visualization. And triamcinolone is the best visualization thing you can use. I actually use a finesse loop in those cases if it's not coming directly on traction. The finesse loop is fantastic for such cases because you can change how much you extend it and therefore change how flexible it is. The finesse flex loop that Halcon makes. I used to be using a Tano scraper, but I think this is 10x better. If you haven't used it, my suggestion is to try it out. It changes the dynamics of the surgery a lot, and it also helps you peel the ILM in a very, very easy, simple way. Especially if you're worried about in these cases, if I'm peeling ILM, I'll actually use the Dork blue. Tissue blue helps a lot to determine where the ILM is and peel it. Diabetic cases often have ILM that's a lot more finickier than macular hole cases. So I love getting a large sheet of ILM and peeling it all at once. It just makes it easier and it looks nicer. But in diabetic cases, the peels can be fragmented. And to have patience, it's best to have color so you can see exactly what you're peeling.
Thank you so much. Thank you.
So
Is
I
there-
had a question for sir that sir, do you do diathermy to the neovascular points on the disc also?
No. That's a very good question. I worry about the closest I'll do is any nasal vessels on the disc that are neovascular. I'll get to the edge of it. I'll decrease it down to 10 from 20% and do my best to stay in the actual vitreous space. Um, if you have a bleed on the optic disc that won't stop, what I do is I bring the pressure up to a very high number, 70, 80, and go for 3 minutes under air and let the eye actually figure out that it needs to make platelets and stop the bleeding. Um, I've found it not to be useful to go deep into that. The best thing we can do when you have severe traction on the disc is to carefully cut and manipulate so that you're not going to cause a bleed. I think that's the most important thing to do there.
So, just a question.
Mhm.
Dr. Raj, just wanted to ask that about the early vitrectomy cases. Do you do in all of the cases, or especially in cases where there is uncontrolled sugars, or you're thinking that
Mhm.
this may progress into a bad PDR or a
Sure.
TRD?
So I think the key is to actually get to them before you're worried about TRD progression from the periphery to the fovea. And yes, uncontrolled sugars matter, but the data is unfortunately not always consistent with that. Whenever we look at large studies with PDR and see what are the key factors, systemic factors rarely make a big deal. Yes, really severely uncontrolled sugars obviously matter, but they're not as important as peripheral non-perfusion and peripheral leakage. Of the two, peripheral leakage on late frames of an angiogram, in my opinion, are the number one predictor of progressors. So if you're taking a patient with early NVD, if they have severe peripheral non-perfusion in 2 years, the chances of them progressing are much, much higher, 70, 80% in fact, versus those who are not. The DRCR protocol AA data using wide field angiography on annual basis on patients with moderate NPDR and seeing how they progress over 4 years shows us very good information as to who will progress and who will not. And we didn't show a big difference in A1C. Of course, in these studies, we always limited subjects to patients who had less than 10 A1C. So obviously, if you have somebody with 15, 16 A1Cs, they're going to progress no matter what. And the reason not to operate on them is because their white blood cell function is reduced and they have a higher risk of endophthalmitis. So, yes, I will try and avoid that. But I also know that avoiding surgery to prevent a potential case, rare case of infection, you're going to miss a lot of patients who will not follow up because they haven't followed up with their PCP. That's where they got this disease in the first place. They won't follow up with you either. So getting to them early, I think, is the best thing you can do.
Thank you.
Thank you so much, sir.
Okay. Okay, thank you, Dr. Raj. It was an amazing discussion. And now we should move on to the next talk by Dr. David Chow. Hello, sir, and welcome to Pan
Good luck, David.
Ophthalmologica.
Thank you.
And Dr. Chow is an assistant professor in St. Michael's Hospital, University of Toronto, and is heading the Toronto Retina Institute there. He has authored over 50 publications and presented over 300 talks worldwide. His main interests have been vitreoretinal instrumentations, for which he has many patented designs. And now we should hear him what he has to say about the new xenon light system for the recently introduced Unity platform, the vitreoretinal cataract system by Alcon. So over to you, sir.
Thank you. So, yeah, we're going to talk a little bit about the new light source on the Unity VCS. And I am a consultant for Alcon along with a lot of other companies. Endoillumination is a topic I've talked about for over 20 years. And over 20 years ago, I was very fortunate to get involved with one of the engineers who was designing, at the time, the first xenon light source for retina surgery. And it kind of opened my eyes to all the science and all the issues that are involved in light source development. And then over the last 20 years, I've stayed involved in kind of that area of our instrumentation. When we talk about this new Unity light source, the bottom line, I guess the first piece you need to understand is that Alcon's decided to go with an LED light. And why LED light? Because essentially LED lights have become the most energy efficient and rapidly developing lighting technology. They use about 75% less energy than other light sources, and they last a lot longer, 25 to 30 times longer. The design that the engineers decided to go with is with 3 LEDs, an RGB, red, green, and blue, and then the optics train combines them all together. And this has allowed then, as a result, Alcon to have the ability to create color tuning and filter options. And on the platform, when you get a chance to use it, you'll see that there are really 4 preset color options: cool white, warm white, yellow, and light sentry mode. There is also a surgeon customization of the color option, which I'll show you in a slide coming up as well. One of the important features of the design is that the engineers have decided to go with a 450 nanometer UV filter, which is important when we start to talk about safety, and there is no infrared filter. There are 3 ports on the platform to connect 3 different light sources. The light bulb shouldn't need to get changed during the lifespan of the machine. That's a nice little kind of pearl because of the extended duration of the LED light bulbs. So that's nice. And then the first thing we basically did is I looked at calculating the safety of this new LED light source. And so when you talk about calculating the safety of a light source, you really need a spectrophotometer. This creates a spectral curve for every light source. And you then look at the intersection of the spectral curve from a given light source with the aphakic hazard curve. That's the yellow line you see on the left there. And that is basically a curve that was created from monkey work by Dr. Ham many, many years ago. That is really the FDA standard for determining whether a light is safe or not. And as you can see, the lower you go into the UV range, the higher the risk of creating phototoxicity becomes. And so when you really create a calculation of the safety of a light source, it's really an area under the curve from the spectral output of the light bulb and the aphakic hazard curve, and this is called the aphakic hazard sum. So here you can see I did that with about 12 different probes at each setting on the Unity, and you can see here the curves obtained with the 4 preset options you will have: cool white, warm white, yellow, and light sentry, basically showing a progressive increase in safety as you shift towards yellow light. And that's no surprise. And as you can see on the spectral curves, you're pulling out the blue LED component and you're reducing the amount of blue light. And to no surprise, you now see when you get up to light sentry mode that you're 9 times safer in terms of safety calculations than you are using cool white. What's important is to see how does this compare to the constellation. Most of us have been using the constellation for over a decade now. And so what does this compare to the constellation? And you can see here that even cool white, which is the least safe of the options on the Unity, is about 20% safer than what we had on the constellation Xenon. And the reason for that is what I had told you the engineers did with the UV filter. On the Constellation, we had a 435 nanometer UV filter, and on the Unity VCS, we now have a 450 nanometer filter. And that explains really why, even on cool white, you're still safer than what you were on your Constellation. What you're looking at here is me doing a Corvette, flipping between the 4 color channels. So you just saw the cool white, the warm white, the yellow, and this image there is of the light sentry mode, which is quite yellow, but very safe. Here's an epiretinal membrane, the same thing. You're watching me kind of shifting through cool white, warm white, yellow, and then on to the light sentry mode, which again, very safe, which might be very useful if you're doing an extended macular peel, but you may not like that it's so yellow. And we'll come back to an idea to try and address the yellowness of that image this here is showing the ability for you to customize your color on the screen. So if you don't like any of those 4 presets, you can see here, you can have your assistant kind of drag across the GUI and shift the color to whatever you want. Now, what's good to know about this kind of customization piece is that nowhere on that square can you pull the color to create a scenario that's dangerous. So they've really removed blue light as an option to include in this kind of customization piece. Now, as surgeons, most of you guys really don't care about an aphakic hazard sum. What you guys really should care about is something that's called a retinal threshold time. And that incorporates not just the safety of your light source, but it incorporates the power of the light you're using, your working distance, the numerical aperture of the fiber you're using, and compares all of that to a hazard threshold. And then you can kind of create a theoretic retinal threshold time for any given scenario. Historically, there has never really been a light source that gave surgeons any feedback on what the retinal threshold time was or how you were doing on a given case with this kind of parameter. And so what's interesting on the Unity, and this is buried a little, and I found this when I started working with the engineers, is that, you know, within a couple sublayers, you can dig this out, which are on the case metrics on the Unity. There is this thing called a remaining aphakic time and an aphakic ratio. And really what's very interesting about this is that this is the first time a company's actually put an algorithm in that will look at what light pipe you're using, what the brightness is, how many lights you're using, and then create a countdown clock on really what you're using in terms of the theoretic retinal threshold time. The problem with the algorithm, of course, is there's going to be assumptions. The biggest assumptions that are a bit of a problem are they don't really know where your light pipe is. So they don't know your working distance. And 2, they won't really know when the light pipe's actually in the eye or not. So this is a bit of a fuzzy calculation, and it won't be super accurate, but it is a step in, I think, in the right direction to give us a little feedback on that issue. Well, what about the brightness or power of the light sources on the Unity? Essentially, you can see here that irrespective of what gauge you use, your effective brightness you will get is between 7 to 8 lumens of light. And to achieve that 7 to 8 lumens of light, you can see that the default power setting that will show up on your Unity will vary. To no surprise, the smaller the fiber you're using, like 27 gauge, the higher the power setting is going to be to achieve that brightness. And you can also see that if you're looking to increase the brightness, a given gauge, that the high-end maximal brightness will be higher with a larger fiber, like a 23 gauge light pipe, versus going down to a 27 gauge light pipe. One of the other nice features on the Unity is that the engineers put a little bit of effort into designing a much tighter connection on the light pipes to the light source. And so previously I'd done work on the Constellation showing that when you jiggled your light pipe around, you could get variability in your power output anywhere from 10 to 20%. Whereas on, this video, you can really see as I jiggle around the connection, that the power output's remaining really quite steady and stable on that light pipe. And so that's another little feature that they've tightened up, the consistency of the brightness, irrespective of how your scrub tech connects your light pipe. Now, there is actually an additional light source on the Unity, which a lot of people won't be aware of, and that's this multi-spot laser probe. So this is a new feature on the Unity and allows the surgeons to have 1, 2, or 4 spots when they're delivering their laser. The interesting piece about the design here is that the engineers included a white LED within the optics train of the laser probe. So it's really a lighted laser probe all the time, and with a single LED source, a white LED. And here you can see kind of the spectral curve for the laser probe, the multi-spot laser probe, with light sentry mode on and off. And in this video, you can see basically here, there it is. You can see around those 4 spots, there's a very kind of subtle illumination cone. So, I've had a chance to use this now, and I'll tell you that I think the illumination from this multi-spot laser probe is nice, but I'm not convinced it's enough in and of itself to allow you to do just illuminated laser probe on its own. It's a little weak or dull, and you could see that on my calculations. It's only about 1 or 2 lumens of light. And finally, some of you know I've lectured quite a bit on the Ingenuity or 3D surgery platform. And when I looked at this data, I've now shown you that the light sentry mode on Unity will be a very, very safe imaging or light source advantage. The problem with light sentry mode is it's very, very yellow. And a lot of people may not like operating in a world that's so yellow. And so one of the little tricks I came up with is let's take the light pipe that's on light sentry mode that's so yellow, and then I would white balance out the yellow on the Ingenuity platform so that when I would be watching my Ingenuity screen, it would look normal. However, what I'm shining in the eye is actually heavy yellow light sentry mode. And so this video, you're going to see me basically doing that, which is essentially showing the different settings. And so here, that same case I showed the Yet Remember, going from cool white, warm white, yellow, and then light sentry mode. And then now what you basically are going to see happen is I'm going to pull out on the Ingenuity screen. I'm going to pull out the yellow by going to a temperature setting of 7,300 Kelvin. And now basically you're going to see I'm going to do my epiretinal membrane peel using light sentry mode, which is 9 times safer than cool white. All right. But not have to look at a heavy yellow world as I'm operating. So this is something I'm working with the engineers on as well to kind of create a setting for this moving forward. And I think that is it for me. Okay. I think that's all I got.
Thank you, sir, for the amazing talk. And anyone in the panel has some questions for Dr. Chow?
This is Raj Maturi. Great talk, David. Did you have any thoughts about these multi-spot being available in curved probes and maybe 25 and 27 gauge? Do you know?
Yeah, it is curved, so it does have a bit of a curve to it. I don't remember the actual angulation on it. And I have used it in 25, and I think I've used it in 27 too, to be honest. So I think I have used it in both scenarios. I think the interesting piece with that multi-spot laser probe is going to be from a practical standpoint. I was always a guy that did laser spots that were 300, 300, and 300 for my, my settings. And so for me, converting to a multi-spot was a fairly easy transition. I know at the teaching hospital where I work, there were a lot of other surgeons who love machine gun style. If you're a machine gun style guy, you're not going to really like that multi-spot laser pro. It's going to feel very awkward, and you're going to really struggle to kind of get the spots you want delivered in the way you want them. Um, and I think right now, everybody who's got kind of had a chance to be early users of the Unity with that probe, I've been at meetings where I can hear some of the people shifting their settings up and some shifting down, some saying that, oh, I'm going to use 2 spots instead of 4 spots to allow me to get a more predictable delivery. So yeah, I think we're going to find that multi-spot. It is very good though, I will say. When I'm using that and doing 360 laser on an RD or, um, you know, it hits quick. There's no question. It's quick, and it delivers a good result more efficiently. No doubt about it. But relating to the light source piece, you heard me mention that the illumination is low, and so I'd be careful thinking to yourself that laser probe, its light source will allow you to do just that as a source of illumination. I think it's a little bit on the low side. It's a bit of a struggle sometimes.
Nice. Hey, I really love the one. Can I ask one more and maybe make a small point? Really like the idea of getting at what point the eye is getting toxic from light by looking at the Han numbers. But we have to remember that these Han numbers are all based on healthy monkey retinas, not on diseased eyes that we all treat. So one of the things that I've slowly done over the years is actually whenever I'm changing instruments, whenever I need a break sometimes, especially on tough diabetic membranes and PVR cases, I'll turn off the scope light. I'll take my probe off, let people do what they need to do, but no light going in the eye. Giving the eye a break gives a chance for the metabolism to come back to normal and you can go back at it again. I think giving an eye light breaks are actually very important things to do. We don't have numbers as to how much matters, but something's better than nothing.
Yeah, interesting point. There is no data on that at all. Pragmatically, it sounds like a good thing, but is it a truth or not? I've never seen anything in the literature or even in monkey work to suggest that. Yeah.
Thank you so much, Dr. David Chow. And
Welcome.
we are looking forward to using this new machine. And so, any more questions from the panel, or should we move forward?
Hi. I'm Dr. John from the Philippines. Can I ask regarding with regards to the triple input of the light source? You show the placements of the RGB lighting. Um do they so in the lifespan of the machine, they're not expected to fail. But in the case of if one of the ports do get clogged up or has a problem, the whole system you won't be able to use it. You won't be able to use the endo illumination.
Yeah, I think that's true. But I think you really, from what I've been led to believe, I mean, they have filed with FDA and approval with FDA that they're very confident that really in the lifespan of this light source, you will not need to ever change a bulb. Now, that's from light bulb failure. But what you're hinting at is could something else go wrong with the electronics, or I guess conceivably that could happen. And if it does happen, would you be in trouble with your light source? Yeah, I think that's probably true. Yeah, so that would be a truth. But I think fortunately, or I think the risk of that is pretty darn small.
Okay. Thank you. Thank you, doctor.
Thank you so much, sir. So now we move forward to our next speaker, Dr. Peter Zerman. He's the professor of ophthalmology at Eye Clinic Zurich. And in 2007, Sir completed his PhD on newer treatment options for macular degeneration. He's passionate about retinal and stem cell therapy and has done extensive work on transplant surgeries as well. So let's hear him on how to enhance retinal survival in macular hole repair.
Yes, and thank you so much for the kind words. And I'd like to propose and investigate three various strategies to possibly enhance the retinal survival in macular hole repair. We all know that even after 6 months after successful macular hole closure, there is still a substantial damage in the inner retina, in the ellipsoid zone, in the foveal integrity, and even after 1 year, there are several eyes which very slowly reestablish the foveal integrity and the ellipsoid zone. So we've investigated three different strategies, how it could be potentially remodeled or speed up the natural foveal remodeling. And these are all ongoing studies, but I'd like to share the preliminary results. The first is the reposition flap, so we call it the Shanghai flap, to improve the inner retina. We know that after ILM peel, we find a considerable number of dimples which are which are dissociated optic nerve fiber layers. You can better see in the en face imaging. And so we've compared normal ILM peel on the left eye to the ILM reposition. So it's not an inverted flap. We peel it not off, but reposition it in the natural orientation and push it under perfluorocarbon liquids, and then we have the natural ILM in place. In total, we have included 41 patients until now. And what we have seen is a substantial difference between ILM peel and ILM reposition. Here is, in this case, it is very illustrative to see in one patient, so it's the same patient on the right eye, it was a normal ILM peel where we have a substantial number of dimples post-operatively, although the fovea is closed. And on the left eye of the same patient, we used the ILM reposition. It was also an anatomical success, but we have nearly completely avoided the dimples and dimple formation. And we have statistically analyzed the subgroups, and what we have found is that the retinal nerve fiber layer was significantly better restored in the reposition group compared to the ILM peel group, but it was only true for the parafoveal, but not in the perifoveal group where there was no statistically significant difference. The second technique we've investigated is if micropulse laser may speed up ellipsoid zone restoration, like here in this case with 3 lines improvement. In fact, nobody would like to laser his own macula, although this may not be a bad idea because we know since decades that laser of the retina, so normal laser burns lead to centripetal photoreceptor shift, filling this defect. So it's a kind of wound healing. Of course, we would not use a normal laser, but with a subthreshold laser, which does not produce a real thermal burn, this may be a good idea. And to investigate this, we have conducted a retrospective trial with currently 14 patients, where we have included full thickness macular holes. And it's still ongoing, but I show you only 2 cases where the effect was more pronounced. And like in this case here, after several months, we have started with a laser. Due to a persistent ellipsoid zone defect, and weeks after the laser, the ellipsoid zone was completely closed with a good visual acuity improvement. Here, another case, the macular hole was closed, but the ellipsoid zone did not reform even months after surgery. And shortly after the micropulse laser, the vision increased, the ellipsoid zone remodeled, and we had a 2 lines visual acuity improvement. So all in all, again, it's preliminary, but what we have found is that the ellipsoid zone defect improved significantly in idiopathic macular holes, but of interest, not significantly in macular holes after retinal detachment. It is not conclusively defined and will be investigated, but I think we can see that there is a certain remodeling effect of the laser. The third strategy to speed up foveal remodeling might be an adjunctive PRP, so a platelet-rich plasma that could enhance foveal integrity. And we use it for lamellomacular holes with quite good success in certain cases. And we tried it in a study also in full thickness macular holes. The platelet-rich plasma is prepared fully automatically and delivers a ready-to-use PRP filled in a syringe. So this can be applied at the end of a normal macular hole surgery at your deliberate technique, and under air or gas you can apply this to, for example, 2 drops of this PRP full of growth factors. The patient is advised to position for 4 to 6 hours in a supine position and then in a normal prone position. And again, the results in this ongoing study are various, but in some cases it shows a dramatic improvement. Of course, not in the anatomical establishment. This is defined by the surgical technique, basically, but by the improvement of the fovea, where we have a hint that visual acuity improvement seems to be faster compared to without. In total, we had, together with lamellomacular holes, we had foveal thickness improvement in 45 for 45% of the normal fovea. And of course, tractive eyes, tractive mechanisms improved better than atrophic eyes, but even atrophic eyes improved in foveal thickness for 23%. So it is ongoing, but I think we should think more about functional improvement and not only by anatomical success rate, because we and for that we improved for that we proposed 3 techniques: the Shanghai flap relocation, the micropulse laser, and the PRP. Thanks a lot. Yes, so any questions?
Regarding PRP, sir, I wanted to ask, sir, like that was a very small macular hole. would we have just did vitrectomy and with fluid wave exchange? Would they have closed like that?
Sorry, the transmission is not very good. Can you repeat the question?
Sir, am I audible now? Hello?
Sorry? Yes?
Am I audible now?
You are audible, but we cannot understand so clearly.
Okay, I think some network issue. So I wanted to ask, like in which cases you do PRP? Is it in very small macular holes?
Yeah, currently we use it in all cases of macular hole. We've started with exclusively lamellar macular holes. We have seen that there is obviously a certain effect, although we cannot quantify it yet. The study is not finished yet, but it was hopeful, so we have started also to include full thickness macular holes. And I cannot finally judge what exactly is the effect, but there seems to be a speeding up effect on the remodeling.
Okay, sir. And sir, regarding transplant, I wanted to ask, instead of inverted ILM flap, you are saying you have to transplant the whole thing. So, like the front in, like we do in pterygium, the front in the front and the back in the back, and also the would it matter the medial and lateral side or something like that?
Yeah, so the inverted flap, of course, it relieves the traction, but it is an inverted flap and it does not restore the natural anatomy. And by releasing the traction and repositioning the flap, still there is a damage to the Miller cell end plate, I'm sure. But obviously, covering this damage of the Miller cells seems to be protective for the underlying Miller cells themselves.
Thank you, sir. So, any of the panels have any questions?
Thank you, Dr. Peter, for that great lecture. May I inquire if did all patients receive C3F8 gas post surgery, or was it SF6?
Yeah, mostly SF6 and in selected cases C2F6, C3F8 we rarely use.
Okay, thank you.
Okay, thank you. So,
Thank
we
you.
have no further questions. It's my privilege and honor to invite Dr. Carsten Mayer, and he needs no introduction, in fact, to this August audience. But he's well known to be in the Retina Hall of Fame. He's received multiple awards and chaptered multiple uh, uh, chapters in textbooks. So he's well known for his chromovitrectomy and excellence in macular surgeries. It's an honor, Dr. Carsten, to have you with us, and the stage is yours, Dr. Carsten.
Hello, good to see you. Can you see my screen?
Not yet.
Here you go.
Yes, sir. Sir, open your presentation from the bottom side.
Hello?
Sir, we can see screen. Yeah, we can see your screen, sir. At the bottom side, open your presentation, sir. Sir, in the taskbar, you opened your presentation or minimize this screen. Then your presentation we can see, sir. Minimize this screen.
I can. Scheiße. Eingeben.
Sir, we can see your screen.
You can see, but I can't see my screen. You can see my.
We can see your screen. Minimize this window. Minimize this window.
Ah, okay.
Yeah, minimize this. Yeah. Now
Sorry.
go to first slide and you can go to first slide. Yeah, you can go ahead, sir. Please. Thank you.
Okay. I'm sorry for that. So I would like to discuss with you the geometry, the penetration forces and cutting profile of trocar system. As you all know, different companies prefer different needle tips. We have basically 4 different types according to the nomenclature. The back bevel, which has been used by Oertli, Goyder, and Fritz Ruck. The spear by Alcon, the lancet, which is a 2-step approach, and the spatula, which has been used by Dork and, for example, Bausch and Lomb. The characteristics are for the back bevel that you have an angle surface on the shaft of the stiletto, which induced a sharply angled tip. We have the spear, which is gives you an angled surface, which forms more pyramid-like triangular tip of the needle. And then you have the lancet as described, which is more broader and has 2 secondary grins on the side. And we have the spatula, which is characteristic for its oval tip, forming a smooth closed to the ending. We obtained 11 different trocar systems. We started with 23 gauge trocar systems, divided them according to their tip, and investigated the geometry according to ISO's standard classification, and measured the penetrating force, and looked also on the cutting profile, which is important for the closure rate of our sclerotomies in clinic. So by definition, we have the outer diameter of the tip. We have the inner diameter, which is important for the flow. We have the primary angle of the tip, and in addition, the very tip of the needle, which can be divided in an angle alpha and angle beta of each tip. After these measurements, we started with our experiments. So first of all, we wanted to measure the applied forces which each trocar system was needed to penetrate defined foil, as shown here. And for any needle that you use, you have a characteristic different phases once you penetrate such a foil. You approach the foil, so we have no force. Then you press a tip on the foil, so you increase the forces, which increases to F1. And then depending on the tip and the sharpness of the tip, you start to penetrate the foil, so the cutting phase starts, which then leads to the edges of the cutting mark of the cut itself, which marks then the second F2 mark of the curve. Then you have the dilation phase of the primary bevel, which then continues to the heel, passing through the foil, which is secondary maximum. And at the end, you have the cannular tube is sliding through the cut itself, and the induced force declines. So these are, so you basically, we have 4 different forces which are characteristic for each trocar system: the piercing force, the cutting force, the dilation force, and the sliding force. We applied this to our 11 trocar system, and I will start with a back bevel typed trocar system, where you see that you have they are very steep, so you have a low energy force to penetrate, to approach it. However, you have a steep increase at the end, and depending on the bevel architecture, you have this characteristic V-shaped opening of the foil, which is then characteristic to our sclerotomies on the inside. Very similar, the goiter trocar needed a little bit more forces, but overall you have a similar characteristic profile on the forces, but also this V-shaped cutting profile. And also for the Alcon trocar. There's also an early back bevel trocar, which is similar, and the Fritzrock. So they are all basically similar. The height of the curves reflects the sharpness of the needle and the force to penetrate it. And if you do it under local anesthesia, this is sometimes where it gets a little bit more cumbersome to penetrate and more painful for the patient to insert your trocar system. With the spatula systems, we have even more forces, especially in the beginning. You see there a peak in the beginning, which responds to this round olive-shaped curvature of the trocar. So you need more forces. It's not so defined on a local spot. And you find this more roundish shaped insertion profile on the foil, as shown here by the 3 examples from Dog, Ike Technology, and Bausch & Lomb. And we have the spear trocar system, which also have a very, this triangle shape make a very flat cut through the foil. They are characteristic for low energy in the beginning. However, sometimes you have more higher at the end of the foil when sliding through the cut itself. 2 different systems have been used here, and they show very similar penetration force profiles and cutting profiles on the foil. And in the end, we have the lancet type, which shows very nice, very low energy forces to cut through the foil, penetrate, and the sliding into the profile of the foil. So this shows some benefit, and actually these studies have been done by us a couple of years ago, and I worked very close with Oertli as they showed that their trocar system has a lot of benefits to lower the energy to penetrate the sclera in our patients. And while these early experiments have been done by us while I still was in Germany with 23 gauge trocar systems, Oertli obtained our findings in the 23 gauge trocar systems, and they are now producing and designing a new Calibur trocar system, which uses then low cutting forces to penetrate, penetrating forces to penetrate the sclera, as you can see here. And I've already used their new prototype in surgery, and it really shows a very nice, smooth insertion of the trocar to the sclera. They also changed the sealing of the membrane so you don't have this leakage by going in and out with your instruments, even through longer surgeries. And for us, this blade curvature in the lancet shape form declines the applied energy to the sclera, so it's less painful when you do it under local anesthesia, your surgery, and it shows a very nice closure. So I did a couple of vitrectomies even without any air by the end of surgery, and the sclerotomies were really sealed and showed also a very nice closure rate, and no leakage and no hypotony at day 1 when we observed the patient. So we're moving now on from our experiments have been done with 23 gauge trocar system, and the Calibur system by Oertli is now also designed for 25 and 27 gauge trocar systems, where we find this very favorable wound closure in our patients. And here I show you our first experiments with the comparing the 23 and 25 gauge trocar system, which shows very nicely that you have very low forces at the beginning. We could even and decline it furthermore. And so I think that this will help the future of our surgery, that we can do also surgery under local anesthesia for our patients, and we have a very good closure rate. We are currently expanding our experiments as we've did it before, so we are investigating also other trocar system, so whether other 25 and 27 gauge trocar system have a similar, can show similar results. Thank you very much.
Thanks a lot, Dr. Mayer. I mean, truly fascinating indeed, because as far as we are concerned, on a professional and a practical basis, all we see is whether a trocar is blunt or sharp. But there are so many variables to this, and it's been truly fascinating. If I may just ask one particular question, how do you think these different types of trocars are going to play a role with the scleral thickness? For example, I just came down from operating a case who had a patient with an RD and a high myo. So obviously the sclera is thin. But do you think in your in vivo studies the type of trocar really matters in the wound closure as far as the scleral thickness is concerned?
That's a very good question. I think, well, the wound closure is very critical in high myopics. So usually I tend to make it a little longer because you have just less material. The sclera is thinner, so I want to have it a little longer. But I agree with you, especially when you have complicated surgery, you have to do a lot of maneuvering. You have some kind of bending of your sclerotomy, so you enlarge it. And usually I have the most difficulty as a right-handed surgeon to close my right sclerotomy, because this is a sclerotomy where I probably do 70% of my surgery. And this is probably more enlarged. And the easiest use is a primary infusion. You just sneak it in. So, I mean, I would say I agree, or I would say, well, I think the trocar or the insertion angle and also the shape of the trocar plays a role. You can basically see it in your primary infusion, because there you just insert it and you don't have any maneuvering. And it probably plays the least importance in your dominant hand of surgery, where you manipulate it more and therefore you can enlarge it, you bend it. And I really do it a lot of indentation. I really want to shave the vitreous periphery, and there plays a big role.
Thank you. Thank you. Any other panelists have any questions for Dr. Mayer, please? Thank you. Thank you so much, Dr. Mayer. It's been a privilege and honor listening to you.
Thank you. Good to see you. Have a good day. Thank you.
So we'll move on to the next topic. So Dr. Rajiv Muni is not able to join us right now because he's in the operating room. So I'll just introduce him and start his presentation. So Dr. Rajiv Muni, as we all know, is an associate professor and vice chair of clinical research at St. Michael's Hospital at the University of Toronto. He is internationally known for leading the pilot trial comparing pneumatic retinopexy and vitrectomy, and his innovative imaging research has transformed understanding of retinal diseases. With over 220 peer-reviewed publications and international awards, including the ASRS President's Young Investigator Award, Dr. Muni has revitalized pneumatic retinopexy and earned global recognition. So he'll be talking about assessment of proliferative retinopathy in RRD with SSOCT. Just start the presentation.
Is there pre-recorded audio in the presentation?
Yeah.
I have to share the screen again and switch on with audio. Share the screen with audio.
Sir, may I help you? Carson, sir? Yeah, Dr. Pranav, sir.
Opportunity to present
Is
today
it playing
on
now?
the assessment of proliferative
Yeah.
vitreoretinopathy and
But
rhegmatogenous
the
retinal
volume is low
detachment.
actually.
Yeah, you can help me, please.
Yeah, click on share button. A window will pop up, then click on share sound and double click on first option, that is desktop or screen.
Content only, right?
Yeah, now play.
A novel conceptual framework. OCT.
Can you hear it now?
A novel conceptual framework.
Yeah, perfect.
Volume of your laptop.
We
Perfect.
recently
No problem.
described the
Wait.
morphological stages of rhegmatogenous retinal detachment using swept-source OCT and developed a 5-stage grading scale that can assess rhegmatogenous retinal detachments at baseline. An important feature of this staging system is in stage 3A and 3B, where we develop low amplitude and then high amplitude outer retinal corrugations. Here is a cross-sectional view of the retina, which demonstrates how the morphological stage varies from the leading edge of the detachment to the peripheral retinal break. We know that the retina has been detached for longer around the break, and so we see more advanced stages there, whereas the stage may be stage 1, 2, or 3A near the leading edge of the detachment, where it has been detached for a shorter period of time. But where does PVR fit into all of this? Unfortunately, despite our best efforts, there are some cases that have substantial PVR and significant foreshortening of the retina requiring a retinotomy, and this can lead to an anatomical attachment, but perhaps not the best functional outcomes. The Retina Society created a classification system for PVR at a time when clinical examination and fundus photography were the primary methods of evaluating retinal detachment. The staging system has some relatively subjective aspects, such as the assessment of vitreous haze in stage A. Similarly, in stage C, it's somewhat nonspecific in that subretinal strands or intraretinal PVR or star folds are all categorized somewhat together. In 2003, many years after the Retina Society classification came out, Pasteur published this important paper that documented the presence of intraretinal proliferative vitreoretinopathy. This was an aspect of PVR that was not considered in the Retina Society classification. We utilized ultra-wide field imaging and swept source OCT to assess PVR. We were particularly interested in the early morphological features of PVR on OCT. We carried out a prospective study to characterize PVR using SSOCT, and we were particularly interested in the intrinsic retinal changes. The prospective study that we carried out consisted of 100 consecutive cases of primary rhegmatogenous retinal detachments seen between 2021 and 2023. We utilized the Plex Elite as well as the Silverstone ultra-wide field swept source OCT from Optos. Here you can see a typical Optos ultra-wide field image with variable segmentations, and on the right you can see the corresponding OCT scans. And you can see how the morphology varies with the different segmentations. We must remember that the Retina Society classification did not look at these intrinsic retinal changes that were of particular interest in our study. However, we did classify all of the cases as per the Retina Society classification to see how this classification was associated with the OCT findings. We also graded all the OCT scans to assess the morphological stage of retinal detachment, and we were particularly interested in the appearance and the morphology of outer retinal corrugations. And here are our results. 61% of patients in our cohort had no PVR or PVRA as per the Retina Society classification, and it turns out that the majority of these patients had an early morphological stage of rhegmatogenous retinal detachment. So about 61% of patients in the no PVR or PVRA Retina Society group had these early morphological stages on OCT, whereas among patients that had Retina Society B and C, only 2% of patients had these early findings. Here is an example of a patient who may have late stage A or perhaps early stage B Retina Society classification PVR, and we can just see the beginning of low amplitude outer retinal corrugations. In contrast, all patients presenting with Retina Society PVR-B had significant outer retinal corrugations of high amplitude and high frequency. So we can see that the retinal wrinkling, which is referred to in PVR grade B as per the Retina Society, corresponds to significant outer retinal corrugations. As the clinical severity worsens, the OCT demonstrated progression of the outer retinal corrugation frequency and amplitude. We can see that the frequency increases, the amplitude of the corrugations also increases, and we can note that some of the outer retinal corrugations start to fuse together, and we start to lose differentiation of the retinal lamella. Now, we also classified patients who had Retina Society PVR-C, and we noticed that there were two very distinct morphological subgroups. The first subgroup included patients who had fixed star folds and some intrinsic retinal changes, which we referred to as the intraretinal subtype or the IR subtype. On the other hand, we had a completely different cohort of people who had subretinal proliferation with no intraretinal changes. Let's look at a patient who had fixed retinal folds, or a star fold, what we refer to as the intraretinal subtype. We can see that such patients have significant outer retinal corrugations, and some of the corrugations may even start to fuse together. Here is another example of a patient with the intraretinal subtype of PVR. You can see that the corrugations are starting to fuse together, that there's loss of differentiation of the inner and outer retinal lamella, and there's even some pre-retinal membrane, although the majority of the changes appear to be intraretinal. Here is another example of significant intraretinal subtype of PVR, and notice the significant opacification of the full thickness of the retina, loss of differentiation of the inner and outer lamella, fused corrugations, and a preretinal membrane. Here again we can see another example of a star fold where we see the corrugations fusing together. Now let's discuss a distinct subtype of retinal detachment, which we refer to as the regulated detachments. These are patients who have atrophic holes with an attached hyaloid often, and that are very slowly progressive or non-progressive detachments. These patients have a completely different morphology of retinal detachment because the fluid enters the subretinal space very slowly, and this gives time for the RPE to reabsorb the water component. However, because of the higher osmolarity of this fluid, we don't get the same hydration of the outer retina, and we don't develop outer retinal corrugations. This is why in these cases, because there's no hydration in outer retinal corrugations, we don't see the same intraretinal type of PVR changes. Here we get a very distinct type of PVR changes that are associated with subretinal bands. Here is an example of one of these subretinal bands under the undersurface of the retina, but notice how the inner retina and outer retina are relatively well preserved in contrast to the IR subtype that we reviewed previously. Here's another case of a regulated retinal detachment, and you can see how we can identify the retinal lamella, but note in the top OCT panel that you can see a membrane emanating from the retinal pigment epithelium and growing along the undersurface of the retina. We do see some signs of chronicity, like cystic changes within the retina in this chronic regulated detachment. Here is another example of a chronic regulated retinal detachment. Notice how there's a membrane emanating from the RPE and growing along the undersurface of the retina, very different than the morphological features we saw in the IR subtype. In some cases of regulated retinal detachments that are chronic, we can see that these subretinal bands can result in the formation of what we call tractional outer retinal folds, which are different than the outer retinal corrugations that we see in regulated retinal detachments. So to summarize, rhegmatogenous retinal detachment can be associated with proliferative vitreoretinopathy, which is a significant challenge in our field. Using swept source OCT imaging, we can now categorize patients into two types of PVR. The intraretinal subtype occurs in dysregulated retinal detachments. These are bullous detachments, extensive, progressive, with horseshoe tears in a PVD. And you get a loss of control of the subretinal space because of the constant and high inflow of subretinal fluid that's hypoosmolar. This hydration of the outer retina, we believe, leads to a glial proliferation in the inner retina and to the IR subtype of PVR. On the other hand, the subretinal subtype of PVR is associated with membranes growing along the undersurface of the retina and emanating from the RPE. These occur significantly in regulated retinal detachments, where the RPE is in relative control of the subretinal space. Let's look at an animation video demonstrating the IR subtype. Once you get corrugations, with increased hydration, these corrugations start to fuse and get what we call these M-shaped corrugations where they've fused. You then get a loss of differentiation of the inner and outer lamella, as well as a preretinal membrane. Here you can see significant distortion of the full thickness retina. This is the IR subtype of PVR, and we call it the IR subtype because there are significant intraretinal changes, and the preretinal component seems out of proportion to those changes. And here's an animation video of the subretinal subtype of PVR. Here, membranes emanate from the RPE and grow along the undersurface of the retina. When these membranes contract, they can lead to tractional outer retinal folds. But notice how the retinal tissue, the inner and outer retina, are relatively well preserved with identifiable lamella. In summary, there are two distinct PVR pathways based on RRD morphology, and early OCT changes may be critical for management as well as novel therapeutic agents. Now that we know that there are these two distinct subtypes of PVR that have very specific imaging features, we also understand that they are driven by different cell types that can be targeted. Thank you. Thank you.
Thank you so much, sir, for this enlightening presentation. I think Dr. Rajiv, sir, has joined. So we would like you to comment on your presentation, sir.
Yeah, I think it's just, I think over the past few decades, we've been focusing on PVR and, there's different models where you inject cells or, induce detachments, but we haven't really understood the underlying pathophysiology is related to hydration for dysregulated detachments. And for regulated detachments, it's a totally different pathophysiology. So now that we understand that there's two distinct subtypes, glial and RPE, we can use this for searching for molecular targets, understanding prognosis, and therapy.
Any comments from the panel? What do you think about the difference between the subretinal and the intraretinal regmatogenous retinal detachment changes? Like, do you think the subretinal is more difficult to manage or the intraretinal?
No, actually, the subretinal is probably the easier to manage because you can just usually grasp the membrane. The retinal structure has not been severely disrupted, other than some atrophy of the ellipsoid zone, the outer retina. So, these membranes you can either ignore or remove if necessary. Whereas the intraretinal subtype is much more complex, because even when we peel a star fold, we often find that there's still significant intraretinal changes that can limit the ability to attach the retina. One important application of this is, for example, if you have a young patient with atrophic holes in an attached hyaloid, this is the type of patient where you want to do a scleral buckle, pneumatic, or something that doesn't involve doing a vitrectomy. Because if you do a vitrectomy in these young patients and have difficulty getting the hyaloid off or causing iatrogenic breaks, now instead of the subretinal subtype of PVR, you're going to create a dysregulated status where they're now going to go down the path of intraretinal PVR. And that's when you can get a real disaster. You have a patient that you should have done a buckle on, but you tried to do a vitrectomy, it redetached, and now they have not only the subretinal bands, but also the intraretinal PVR, and you've converted it into a mess. So I think that this also helps us tailor our treatments better to understand what we want to avoid the most in those regulated detachments, which is a very bad outcome with PVR.
Yes. Dr. John?
Yeah, good. Great lecture, Dr. Mooney. In your current understanding and research on the pathways, is there eventually going to be a big difference in the surgical management or would it come to a point wherein you no longer advise surgical management for the more hydrated PVRs?
So the more hydrated ones, the dysregulated ones, we know that if we attach the retina very quickly, we're going to get outer retinal folds, because those corrugations will lead to folds. So we still like treatments that attach the retina slowly, whether that's pneumatic retinopexy or suprachoroidal viscopexy, which are, pneumatics are first line for these patients. However, in some cases, you have to go with a vitrectomy, and we're understanding the concept that you want to attach the retina slowly, and that's impacting our treatments. In the regulated type, again, it does impact management, because we, again, want to use a treatment that's, less invasive, in the sense that you don't want to go into the eye and create a dysregulated status. So I think that this kind of helps you, plan your management, and also, understanding what you want to avoid. And I think, again, understanding these differences will really help us find molecular targets and therapies that can inhibit these different cell processes, for depending on the type of detachment that you have.
Thank you. Thank you, Dr. Mooney.
Any other questions from the panel?
Thank you. Vaibhav and Pranav, thank you for the invitation.
Thank you so much. Thank you so much for joining us, sir. So I think this is the end of our session. It was a very well managed novel concepts in VR surgery, and we had a chance to listen to all the greats of ophthalmology and retina especially. Thank you to Dr. Raj Mathuri, Dr. David Shao, Dr. Peter, Dr. Karsten, and Dr. Rajiv for making this such a wonderful webinar. Thank you so much.
Thank you, Dr. Pranav. Welcome one and all to our diabetic vitrectomy masterclass session of Pan Ophthalmologica 2025. I take this opportunity to introduce our first speaker for this session, Dr. Sangeet Mittal. He is from Jalandhar, India. He is a very well-known vitreoretinal surgeon and innovator, and has a lot of academic laurels to his name. And without further ado, sir, let's dive deep into your talk about tackling tabletop TRDs. Thank you, sir. Welcome.
Thank you, Dr. Rachita. Is my screen visible?
Perfect. Yes, doctor, it's visible. Yes, visible.
Yeah.
Thank you.
Thanks a lot, Dr. Rachita, Dr. Weber, for giving me this opportunity. I'll be talking on vitrectomy for tabletop RD my way. Just not able to see my screen. Yeah. So I'll just give a glimpse of some techniques that I use in managing this tabletop TRDs. So tabletop TRDs, as we all know, is not moving. I'll share my screen again. Just yeah. So tabletop TRDs, we all know that new vessels grow along the trampoline-like contour of the posterior hyaloid and using it as a scaffold. And combined with the anterior posterior traction of vitreous on all sides, it gives an appearance of a tabletop. It's just like a plateau on the retina surface. And it's difficult to treat as the membranes formed are not glued but are nailed at multiple epicenters. So you just can't peel it off. You have to cut along these epicenters one by one. And various techniques have been described to deal with this, the technique of segmentation delamination or end block dissection. But both these often need fourth port or combination instruments, and finding proper plane of dissection remains a challenge in both these techniques. So from our past experience, we know that dissection of membranes is easier if plane of dissection is found. And vitreous cases all causes second membranes under the visible membranes, and the second membrane is usually fused with the primary membrane at the disc. And it's also easier to work around the tractional points than to cut or dissect them. So uh, my first way of dealing with these type of extensive fibrovascular proliferations or a tabletop TRD is around the table dissection. And what we do in tabletop in around the table dissection, just go through this video, which will explain.
Two steps. First is to remove the membrane from optic disc with the help of forceps, thus creating a proper plane of dissection. The second is to create a wedge between central and peripheral retina and induce PVD in the peripheral retina. This helps us to attack the tough epiretinal membranes from all around. Peripheral vitreous acts as a third hand and keeps the posterior membrane held up while dissection. This eliminates the need for bimanual dissection. Again, you can see that the small sphere of influence and low flow rate of 27 gauge cutter avoids retinal tissue being engaged into the cutter while working very close to the retina.
Around the table dissection, we start the dissection on the disc.
The cutter is being used as a forceps, suction and scissors rolled into one instrument.
And then we create a wedge between the central and peripheral retina so that we can attack the membrane from both the sides.
Even a very mobile retina remains quite stable during vitrectomy. Two steps. First,
so this is the post-op picture of this patient, 3 months post-op and 1 year post-op. The patient regained good vision of 6/12 in this eye. So the basic advantages of plucking the membrane from the disc is that you get a proper plane of dissection, and then you can proceed inducing a PVD from the periphery, and then you can attack the membrane from all the sides. The second tip is that I always use the smallest gauge possible in diabetic retinopathy, because then it gives me an access to a very small planes which are present, and to elucidate this, I'll just show this case which presented to us with bilateral this extensive fibrovascular proliferation with causing a tabletop TRD. And this we started with the 27 gauge.
Have revolutionized the way we manage combined RD. The small size of the cutter enables it to go in between very small crevices, thus eliminating the need for scissors.
The smaller size, you can go in between very small epicenters, and then you can open the membrane.
It can even go between the epiretinal membrane and retina, lifting the membrane up and separating it from overlying retina. This enables a safe dissection of membranes. The small sphere of influence avoids retinal tissue being engaged in the cutter while cutting these membranes. 7 times low flow rate as compared to 23 gauge helps to work very close to the mobile retina without causing any collateral damage. Small port of 27 gauge cutter lies very close to the tip. This allows the cutter to easily lift, grasp and dissect membranes without the need of forceps. Thus frequent exchange of instruments is avoided and vitrectomy becomes faster.
So these are the post-op pictures of both the eyes. Again, the patient regained a good vision in both the eyes. So what I said is like a smallest gauge, and you do start the membrane dissection from the disc, advance towards the periphery, and you can get the membranes all around one by one. And but if you're the disc in the starting, you have to go bimanual and start from the periphery. In these type of patients, you have to. I prefer to use a 26 gauge needle to dissect these membranes. And just show you a small video of this 48-year-old female who presented to us with this type of tabletop TRD, and the patient's vision was just PLPR. And in this kind of patients, because we can't see the optic nerve head, we can't take the membranes from the disc. So we generally plan a 4-port vitrectomy. We do a bimanual. We remove the vitreous skirt, and then we access the central periphery. We hold the membrane from one side, and then we start dissecting with the needle. And you don't need any other instrument in these type of membranes. You just lift the membrane softly and gently, and just with the needle you can dissect all these epicenters, and one by one. And you can also separate the membrane from the retina easily. So again, you see one by one, all these epicenters are dissected by this sharp needle only. This is a 25 gauge 1-inch needle, and it gives you a very good grip. So you just have to be careful that you don't pull it too much. That will cause retinal breaks. Otherwise, there won't be any, if you're doing it softly, there won't be any retinal breaks associated with this. So this is the, once you have completely removed the membrane or dissected the membrane, you can remove it with the vitrectomy cutter. And this is the post-operative. Again, the patient's vision was, post-op vision was 6/18 in this eye. And you can see, based on this, we designed a new instrument that we call Arrow. And this can be attached to your extrusion port. And you can use this also in dissecting this membrane. This again, another video showing how to use this instrument.
is a disposable cannulated MBR-like instrument. It is shaped like a spear in the front with a pointed tip and sharp lateral edges. This is used to dissect membranes in PTR or retinal detachment. The shaft is long and curved to conform to the shape of the globe. It has got a small opening just behind its sharp tip. The disposable needle can be connected to the extrusion pump with a reusable handle. This is helpful to remove excessive blood during dissection and to perform hydro or visco dissection. Because the dissection is done using simple to and fro motion, the membrane removal can easily be done by the non-dominant hand also. The long and curved shaft protects the lens and the retina from injury during dissection.
My last tip is like you see these are long-standing detachments and there is very thick fluid which remains post-operatively. So even if you have done a good vitrectomy and managed the dissection without any breaks, you may have to create a retinotomy to get out that fluid. Otherwise, it stays for a longer time. So what I do is I just inject gas in these type of eyes and make the patient position prone. This is similar to a mechanical displacement of the submacular hemorrhage that we use for managing those submacular hemorrhages. So that gas just pushes the fluid outside the macula and the fluid gets absorbed early. And this is another video which shows this technique being used. Like you see this was a extensive again fibromuscular membrane. There was a lot of detachment. So once we have completed the membrane dissection without any breaks, there was still a lot of fluid. And if I let it remain like this, it will take months for this fluid to go off. So after doing the ILM peel in this patient, we just we did not create any retinotomy, but we used gas as SF6 gas as a tamponade, asked the patient to lie prone for 3 days. And this is like 1 week post-operative. And you see the fluid has gone and the retina was attached. And these are some
Using
of
the same technique.
minor cases.
Like a bird on a tree, I'm just sitting here. I got time, it's clear to see. From up here, the world seems small. We can sit together.
I can say that all these techniques, if we combine them wisely, we can get very good results in these eyes. Thank you.
Thank you, Dr. Mittal, for those excellent cases and those pearls of wisdom. I had seen this video of yours using the arrow, and it was very fascinating that we can use an instrument. Sometimes I think we can even use the cutter also to just slowly separate these membranes when we are operating. And one question I would like to ask, sir, this is when the membranes are looking mature, like some of your cases, they were not looking very vascular. It's very easy to find that plane of dissection and slowly, almost en bloc, we can remove that tabletop also. But what is your approach when we see very vascular TRDs? Do you go ahead with like a pre-operative anti-VEGF injection?
Yeah, definitely in those vascular TRDs, I definitely give anti-VEGF 2 to 3 days before surgery, and that definitely decreases the vascularity.
Yeah.
But then you have to take care that you have to take the case up for surgery within a specified period of time.
Yeah.
Otherwise, that may lead to formation of retinal breaks and cause a combined retinal detachment. Yeah. And with this arrow or with the needle, you can use it. You can attach it to your extrusion pump. So if there is a bleeding over there, you can always like remove the blood side by side just by pressing your foot pedal.
Thank you,
Where
sir.
is this arrow needle available?
It's commercially available, I think, with Epsilon. They sell it.
Okay. And the 26 gauge you are talking about, is it the normal 26 gauge? The
No.
length of the
Yeah, it's not a 26 gauge. It's actually a 25 gauge 1-inch needle. So that's also commercially available by BD, and it's a very cheap. You can say it's hardly 5 rupee instrument, and you can use it very nicely. Yeah.
Yes, sir.
Great lecture, Dr. Mittal. During your tabletop surgeries, are you using a higher infusion IOP during the
Uh,
surgery? Do you
not
constantly use like 60 mmHg or?
No, I generally do my vitrectomies in these cases at around 30 millimeters of mercury pressure. And once I had completed my dissection, I then reduce my pressures to about 15, 16 when I'm doing either laser or either ILM peeling, so that I can see whether there's any residual bleeders left or not, so that can be cauterized. Yeah.
Okay, doctor. Thank you. Thank you so much.
So
Thank
do
you.
you use that pick forceps which is available?
For
Pick forceps are also similar to what you showed, no? Like for
Yeah.
picking up the membranes, these are
we
also
can
useful.
we can use a pick instead of a needle, but the only problem is it's not very sharp. And if you try to cut the vascular centers with the pick, there will be a lot of traction leading to either bleeding or breaks. So the needle is very sharp, and the vascular centers get cut off, just like if you're cutting a cake or something like that.
Any more questions from the panel? Okay, I think we can go on to our next talk. Thank you, Dr. Mittal. Thanks a lot.
Thank you, Dr.
Is Dr. Mitali here, our next panelist? Okay, I don't see her. I then take the opportunity to invite our next speaker. Welcome, Dr. Noor. I don't think she needs any introduction in this forum, but yes, she is an internationally acknowledged vitreoretinal surgeon, clinician and academician par excellence. We're really excited, Dr. Noor, to listen to and learn from your experience on diabetic vitrectomy. Over to you, Dr. Noor.
Thank you. You're very kind. And also thanks for the nice invitation and in this insightful day. So it's very important to share our knowledge to do our best to protect the vision of our patients. So I'd like to share my screen. Let me. Just a minute. Entire screen. Let me. So it's a new computer. I'm sorry. Documents. I prepared it in my screen actually. So why I cannot share that one? No.
Noor, I'm Marcelo South from Argentina. Just press the green bottom you have on the top of the Zoom, share.
I did it, and then
yes.
So I
Or
it's
sometimes
search. Oh, sorry, I'm really very sorry. Why not? So it is complicated. It's not the usual now. New. Let me see.
Yeah.
I don't know. Maybe let's skip me. I have to work on it, and then I will find the way to share my open PowerPoint presentation, and then I will be talking the next one, if it's possible. I don't want to make you wait. Sorry. Okay.
Okay.
Thank you.
All right, Dr. Noor. Yeah.
Sorry.
So, while Dr. Noor is getting ready, I'd like to invite our next panelist. Dr. Ruchir is available. Yeah,
I'm here.
yeah, Dr. Ruchir is here. Over to Dr. Ruchir to introduce our next speaker.
Yeah, thank you, Dr. Rachita, and thank you, Vaibhav and the Pan Ophthalmologica team for this great initiative. So I would want to introduce and invite Professor Dr. Marcelo Sass. He's a renowned retina and vitreous specialist based in Buenos Aires, Argentina. He has over 3 decades of clinical, surgical, and academic experience. He serves as a professor of ophthalmology at the university, and he's the head of the retina section of the hospital. He's a former president of the Argentine Society of Ophthalmology, and he's recognized for his contributions to retinal research, including his work on retinal progenitor cells. Sir has authored numerous publications, book chapters, and surgical innovations, earning national and international awards for his excellence in ophthalmic care and education. It's a great honor, sir, to listen to your experience in managing complicated diabetic cases. Over to you.
Thank you. Good morning from Argentina. Thank you, Rashid. Thank you, Rashida. Thank you to my friend Baibad for the invitation. This is a very pan ophthalmology retina world. Very happy to be here with you. And I'm going to share my presentation about. Can you see me now? Can you see me?
Yes, sir. You are visible.
Yes, we're going to speak about. So thank you first of all for this amazing webinar of all the specialties all around the world. No, so we're going to speak now to diabetic vitrectomy, my current techniques and my current indication for all of us. Is my financial disclosures. As you know, diabetic is a very difficult disease in all around the world, in Latin America, in these kind of diseases, and you can see the numbers of all the patients they have diabetic retinopathy as a cause of blindness in a PDR or diabetic macular edema. So you have to be very aware in where to avoid these kind of patients to go to vitrectomies all over the coast. And we are in a pharmacology area because we understand that diabetic macular edema is an inflammation disease with leukocytes, with tissue remodeling, with vascular permeability, and this inflammation gives us macular edema and retraction or no traction. As all we know, the diabetic retinopathy, in diabetic macular edema, and retinal and PDR, it's a multifactor and combination of several different mechanisms, alteration of mechanism, inflammation, genetic, systemic, duration of the disease, high pressure. So we have to be in charge in all these kind of things before to go to operation rooms, doing the personalized treatment in all of our patients because we need it, because and the result will be better if we use a personalized treatment in our medicine, our practice. The Epacorus group, where we belong, Dr. Arevalo in this paper published one of the first experience in 2019 of the using of bevacizumab in the pre-op in PDR patient with good results. And now it's a very useful tool to use this kind of pharmacology area in the pre-op of our patients and use, as we have seen some image of the paper published in the 2019. Also, there's a very nice publication about this Crohn's syndrome in the PDR patient and review. And sometimes when they have a very vascular and hemorrhagic patients with PDR, we have to be aware with the warning to avoid this Crohn's syndrome when we are injecting in the pre-op bevacizumab and we go into an operation room, because we can do some more disease and more PDR and a difficult surgery avoiding and to do this Crohn's syndrome published in 2021. Also, we discussed about the gauge. If we are using 25 or 27 gauge now with the new machines, going to hyperbit probe. I want to show you some cases on my practice of using that. But I think that we have to use the gauge that you prefer. I mean, in my practice, I use in 100% the 25. But sometimes I use the 27. I don't use anymore the 23 gauge, and then we're going to discuss the panel with the panelists what gauge is that they prefer. Now, also we operate the diabetic macular edema. We have traction. When we have traction macular edema, we have to operation room to take the membrane, to take the posterior hyaloid, to avoid that this traction macular edema to get worse and lose visual acuity. In 2020, we published with Dr. Wilite U from Costa Rica. This paper was in PubMed. You can read it and you can find it about the macrophotocoagulation in diabetic macular edema to compare micropores to anti-VEGF, so conventional to conventional photocoagulation, and to avoid visual acuity and to avoid in this kind of situation. Regarding the current indications in paraspinal vitrectomy in 2024 or 2025, we have to know that these 6 are the indications to go to OR when you have a PDR. Vitreous hemorrhage, traction macular edema with macular traction, premacular fibrosis, traction retinal detachment affecting the posterior pole, combined rheumatocynous and retractional GDR, or neovascular glaucoma with vitreous hemorrhage. But now we know in October 2025 that we are in an early paraspinal vitrectomy area. We hope to operate the patient before with early vitrectomy, because early vitrectomy gives us stabilized eye permanently, is very cost effective, avoiding anti-VEGF therapy, prevent GDR and combined retinal detachment, reduces the complication of the treatment, and reduce the burden of the patient with VR injection, and we are injecting. So now we are in the early paraspinal vitrectomy area, and it's very important. These are very examples of our clinic, and we have to watch in the pre-op 6 features that we have to wait, and I'm going to show you. If the patient have rubiosis, if the patient have a PVD, because I'm going to speak now about what is the vitreous role in the PDR, size of avascular area, if the patient has or not has the PRP, doing the PRP in the pre-op, if we're going to operate the patient with the PDR, and you can watch the retina, doing the more PRP to avoid bleeding during the surgery. Also, the age of the patient, obviously the systemic control, and also in the pathology is unilateral and is bilateral. There's a nice paper in 2016, 9 years ago, there was surgery of PDR, Yusuf and Trick by Tamar Mahmoud from USA. A friend of all of us, are expert in this kind of techniques about doing obviously a early vitrectomy published 9 years ago with all the maneuvers we have, all the tools we have, and all the toys we have in the OR. Also, Maria Berrocal, an expert vitreoretinal surgeon around the world, in the presentation gave us this nice information about Ono and some people from Japan, 2005. That the vitreous is the enemy in PDR. If you have a patient with no PVD, the progression can be 44%. We have partial PVD with thickness of posterior fold, it's 100 progression, and if collapse, it's 0%. So we have to watch and put the focus in how is the posterior hyaloid, how is the vitreous in the pre-op doing an ultrasound, and also watching in the intra-op. Early paraspinal vitrectomy was published by Maria and his son Luis Acaba Berrocal in 2021. A very nice paper is in PubMed about doing an early vitrectomy in published. That the early vitrectomy give us less cost, less burden, and obviously good results. Now we are in 2022 or 2025. All this kind of technology of 3D viewing, magnification, NAHs, chandeliers, 25 gauge vibrant probe, chromovitrectomy, peel, chandelier lights, obviously wide field non-contact lens. We have a lot of toys in our operation rooms, give us better and better and better results, and we have to be in charge of this. And the surgical targets in PDR, obviously, is to remove the cataract if you have a vitreous cataract or vitreous hemorrhage, remove the fibrovascular tissue, avoiding retrograde breaks, reattaching the retina, doing all the PRP, and also to the tamponade. Can be gas, can be air, or can be silicone oil in the base of the case in our surgeon. I'm going to show you some examples just to discuss with the panel. In the upper left, you can see a tractional macular edema. That surgery was it's an old surgery. When we began with the digital area with the Ingenuity, we can do the chandelier lights, and you can see also now it's very to do the indentation. The chromovitrectomy gives us the visualization of the posterior pole and the posterior of epiretinal membranes, and you can use the fine slope, very useful to peel the ILM or to peel the epiretinal membrane in a very nice way. In that case with the direct contact lens. And also in the down right, you can see a patient that have a vitreous hemorrhage. Then we have also a membrane. In some cases, I use dexamethasone in the post-op in the upper left very nicely, and it's very useful pharmacology to avoid in the patient that has bad follow-up, to avoid rebounding the macular edema, or to give inflammation with the dexamethasone, using it in the intra-op. and it's very useful. We published with our group of PACORES in 2020 some kind of, in the retina journal, some kind is when you have an aphakic or pseudophakic or the posterior capsule is ruptured, the migration of the dexamethasone implant in the anterior chamber in some kind of cases, and you can see that can happen. It may be in 10 or 20 or 12% of the patient if you have an aphakic or posterior rupture or YAG laser, and you have to be aware in this kind. And you can see it on the journal. This is another case with a combined PDR, when you can see all the members. This is a very new, and the patient also have the macular hole there. You can see how we are draining the blood and the subretinal fluid through the macular hole with a vitrectomy probe and all the overlay. Then you can see very nicely, and how nicely we can have the focus, the magnification. We have the filters in our Ingenuity equipment to you can use the yellow one in this kind of patient that have no PRP before. It's a virgin patient with naive patient, and you can have a unimanual or bimanual using the forceps, using the scissors as another
For a moment.
colleague.
I think your screen is not getting shared. I think Dr. Noor has started sharing a screen.
So I'm going to continue. You can see how nicely we can use a bimanual technique using the forceps, and you can use the vitrectomy probe with the bevel. I use the scissors, vertical scissors, and you can see, but I use in a practice bimanual techniques in this kind of PDR patient because it's very useful. Try to avoid heterogeneous retinal breaks, taking all this tissue over the retina to relax the retina, to obviously to attach the retina. And in some cases, you have to have perforated liquid just to attach the posterior pole, to give some laser in the heterogenic breaks, and also to complete the PRP better visualization with good results with non-contact wide field lens imagination. Now, the other technique is the segmentation technique. You can see in the down right, how can we segment all these membranes in naive patient with a vitrectomy probe. I try to avoid diathermy. I put ocular pressure in 45 or in 50 just to avoid vitreous hemorrhage. And in some cases, when you detach the posterior hyaloid, you can do a heterogeneous retinal break in the periphery. So you have to avoid, and you have to laser all this kind of patient, and you can see now very nicely how to do the segmentation technique, and you have with good results in the down right patient. I'm going to show you, and this is the results with all the gas bubble, the PRP, the laser, the macula was stable, and the patient have the retina was attached with this kind of OCT, with kind of some kind of edema in the we can do to in the posterior pole. So as a final and take of messages, always remember in 2025 when you're doing a postpartum vitrectomy in the PDR, my tip and tricks also always remember this, that you have to need a surgical plan, a combined postpartum vitrectomy with cataract surgery in patients that have a very aggressive PDR or more than 45 years old. I do combined procedure, new technology for 25 or 27, using uni or bimanual. It depends on you're using now. Some people, some colleagues from Europe, they are in favor of bimanual or unimanual. Use the technique that you are better comfortable to do. Do in 100% chandelier lights, because chandelier with the Ingenuity gives you visualization, magnification, and filters. Also, I use the anti-VEGF therapy that we published with the PACORES group as a very useful tool to avoid bleeding junior and remember the current syndrome. Obviously, we use the wide field visualization with non-contact lens, and to be efficient and to be meticulous in our technique, thus avoid heterogenic, bleeding, complication, traction detachments, and we want to gain vision and not to also operate. Just to go to be effective and to be meticulous in all the technique with all the technology we have now in our operation rooms. As a final conclusion, we operate the patient. We all be our surgeons, but we are doctors, and you have to be in a group with the internal medicine, diabetology, ophthalmology, and the family as a team. You need the compliance for the patient to understand what's going on with the eye, to understand what's going on with the disease. So we need a family with a group and education of the patient and all the drugs we have in the pre-op that I spoke before, subtractional, and now we are on a 3D surgery bimanual using that I spoke to you before about the pre-op anti-VEGF as a pharmacology area, and to be effective, just avoid complications. So thank you very much. I think I try to resume in these 15 minutes all my techniques by unimanual, by manual, to be safe, to be effective, to understand the operation of the patient, not only an eye, and to be effective with the techniques with unimanual or humanal or the pharmacology that's up. Thank you for your attention. Thank you for the invitation, and open to questions and your Q&A. And thank you so much, and keep in touch. I try to, I'm going to share, and that's it. Thank you so much again.
Thank you so much, Professor Marcelo. That was a wonderful talk. I mean, it was such a comprehensive talk. You've spoken about everything in diabetic vitrectomy. And as you said earlier about the 27 gauge system, the smaller gauges, I think both the concept of early vitrectomy and smaller gauges is now being adopted by younger surgeons as well. Like Dr. Sangeet also showed his videos with 27 gauge. I think most of my colleagues are now shifting to smaller gauges, and definitely early surgery gives a very good outcome. One question that I had for you is, I have had cases with tractional diabetic macular edema that worsened after the surgery and the edema would never go away. So you think there is a way of identifying such patients in whom the edema will eventually come back after vitrectomy and they do not respond to any treatment later on?
Yes, it's a very good question, Rishi, because we don't have a biomarker in the pre-op to understand which patient is going to have a recurrent epiretinal membrane. So in this kind of very aggressive PDR patients, I try to peel ALM, because I want to peel ALM just to avoid. There's a controversy in the literature, because I'm out also in the epiretinal membrane disease, not diabetic, epiretinal membrane disease. There's some controversy about to peel or not to peel the ALM. But it's kind of very aggressive and young patient when the follow-up is very difficult. I believe that to peel the ALM will be better in the big follow-up because I would need to peel. In the traction macular edema, also I need to peel. But as I said before, Rashid, check the posterior hyaloid. The posterior hyaloid is the enemy there, not the membrane. You have to peel because some kind of diabetic patient have kind of vitreous kisses. So sometimes you are staining something that you believe that you make a correct PVD during surgery, and it did not. So you have to peel and to stain this kind with a triamcinolone. I use triamcinolone in 100% of the cases as inflammatory, and to watch and to see as a chromovitrectomy the posterior hyaloid.
Right, sir. Thank you. Thank you so much. Any questions from the other panelists or from the audience?
Thank you, Professor Zaz, for that great lecture.
My pleasure.
I saw in some
pleasure.
Yeah, I saw in some of the post-operative photos you had laser marks underneath some of the light membranes. Do you recommend completing all the endo laser, even if there are light membranes? I think it was in your last slide in the nasal section.
Yeah.
The goal is to
Yeah.
just always complete all the laser.
When you are doing, it's good question, John. When you are doing a PRP, do a complete PRP. You never will apologize with the patient with the retina to doing a PRP when they complete over the vessels, because PRP gives you less bleeding, and also in the neovascular tissue, do PRP as a photocoagulation because you are stopping the bleeding. So now maybe if you have with the Unity machine or the Alcon, that we have a multifocal PRP technology, also will be useful, and also will last in less time, in 30 or 40% less time to doing a PRP in the intra-op. But laser is a very useful technique there, and I think that you need to do it in the complete, and also in the periphery. So the chandelier gives you the visualization to do it, not the posterior pole, not only the arcades. You need to do it in the periphery also.
Thank you, Professor Zaz. Thank you.
Thank you,
My
sir.
pleasure, John. My pleasure to all my friends. My pleasure. Anytime.
Over to Dr. John for the next talk.
Yes. Thank you, everyone. Good evening. It's my pleasure to introduce our next speaker, Dr. Carlo Antonino Nasol from the Philippines. Dr. Carlo pursued Vitreoretina Fellowship at the National University Hospital, NUH, in Singapore. He is currently the overall Fellowship Training Officer for Ophthalmology at Cardinal Santos Medical Center and Chief of the VR section at Fatima University Medical Center. He is affiliated with numerous eye centers such as Perfect Sight, Pampanga Medical Specialist, Tsuchi Eye Center, and Novagen Eye Center. Among his many achievements, he serves on the panel of experts for the Philippine Diabetic Retinopathy Preferred Practice Patterns. He leads the retina section at various eye centers and has been recognized as a speaker and contributor to many vitreoretina conferences such as the APVRS, EVRS, and URetina. He specializes in retina surgery complications such as diabetic tractional retina detachment and complex cases. Allow me to welcome the very dashing and insightful Dr. Carlo Nasol.
Okay, good evening, everyone. It's so hard for me to follow Dr. Marcelo's lecture. Um, just to give you a brief background, so I made it easy. It's diabetic retinal detachments made easy. I made a cheat sheet at the end so everybody just can listen. So I have divided my lecture into the pre-op, intra-op, and the post-operative way. So first off, pre-operative, always do shrink the neovascular complexes. You have to reduce the bleeding. You can use your VEGFs. You can use your bevacizumab or ranibizumab. As stated by the previous lecturers, you can use it for at least 3 to 7 days for pre-op. And there is a meta-analysis that if you use your pre-op VEGF, you reduce at least 40% of hemorrhages and you reduce OR time by 25 minutes. In between the VEGFs, ranibizumab edges over bevacizumab for faster regression. And again, remember the timing. If you do it less than 2 days and more than 10 days, in less than 2 days, you might have persistent bleeding or risk. And if it's more than 10 days, you might have what you call the crunch syndrome. So in our practice, we do go for multi-level practice. So usually injected on the superior part if you're just not worried about the conjunctiva. But in diabetic patients who have glaucoma or you have tubes or valve, we do inject it at the most posterior part of the eye. So we do spare the conjunctiva for hemorrhages so that the glaucoma section will be happy if you do spare those conjunctiva, which is sacred for them. Next, as stated earlier, wide-angle view systems will always be better to enhance peripheral views. You can use your eSight or BIOS with a chandelier for you to be able to see the periphery. A contact lens such as your Vogue Supermacular for macular detail, and an insight when you do a wide-angle view system, you see a little bit better for 20% for the missed peripheral breaks. Again, only the pitfall for the wide angle system is when you do use a chandelier, you have more glares, and sometimes it obscures the subtle macular traction if you're using a chandelier. So again, we're using the Ingenuity plus the Gauge 27 here. As you can see here, a wide angle viewing system for the diabetic tractional retinal detachment is a must. You can easily shave the anterior and posterior traction so you can be able to see and release the traction on the sides. Now, as a comment earlier, I was happy to hear that the younger surgeons now are using the Gauge 27 bevel tip. The smaller gauge vitrectomy now is much being used, but in certain cases, you can use a hybrid 23 or 25. Usually, sutureless surgeries are much better in comparison to your 20 gauge. 27 gauge reduces your OR time by at least 40 minutes for certain cases, and at least around so you save time with a shorter bevel. The thing is, sometimes the 27 gauge clots, so it's always handy for you to keep your gauge 23s handy by your side. So again, for this case, we use a 27 gauge for a simple vitreous hemorrhage. In these cases, these are the cases that are very ideal for these certain types of your diabetics. So you have to put your anterior posterior traction, and then you focus now on your optic nerve, look for areas of traction. With a Gauge 27, we can just use a uni-manual. You can just go closer to the retina, either remain vitreous, either and clean it up. So with the Gauge 27, you can just go closer to the retina without you having much traction. Next, how do you remove traction? As stated earlier, you have to disrupt the anterior posterior traction as a scaffold. You have to do a 360 truncation with the use of what cutter you can use, 23, 27, or 25, anything cutter. As long as you're comfortable with your cutter, you can use that. Always stay with triamcinolone. As experts said before, you can use your Gauge 27 for ideal for macular hugging TRDs. So you see here, I use a gauge 27. You can go closer to the retina. You can go into that small little crevice in space. You can go shave those areas. You can go in. You can see I was using the old gauge 27 with the 10K cuts. Just clean it up. So you can see here. So with the advantage of the smaller gauge, you can just like go for a uni-manual technique. So you can see here, I do go for a lift and shave technique. If I see a little bit of bleedings, you can go cauterize those small little areas. When you see in diabetic patients, it's always an ideal way to just be comfortable in what you're really doing. So again, I end this case with just placement of a gas and after as a tamponade for this case. Next, segmentation and delamination. The role for this is to relieve the tangential traction from the fibrovascular membranes. You can use a bimanual with the chandelier. You can use your segmentation, such as a lift and shade technique with a gauge 27 vitrector. Again, you can use your hybrid technique, and then sometimes when you do it over Zelus peeling, that's the time when you have your iatrogenic breaks. As you can see here, you can do a lift and shape technique. Engage and then cut. Engage and then cut. What's nice about these things is in these 3D systems is, yeah, you can zoom in. You can zoom in, as you can see here on how I do my surgeries. I really zoom in so I can see the membranes. So this is a bipanel technique with the chandelier. As what Dr. Mittal was using, I'm also using a needle just to dissect. Do the bimanual technique, just lift out all the membranes. You can use a bimanual lift and cutter. And then I usually end up with gas for these cases. Again, we can use your scissors technique. Sometimes those stubborn membranes can be just used by a curved scissors. So bimanual technique using a curved scissors, so it can also be an option. Next, control for bleeding, you can use your 3 things. You can raise the IOP, you can use your endodiathermy, and you can just plug it with your cutter. So any of the three things can be used for hemostasis. Next, again, this is overzealous peeling or iatrogenic breaks. When you're not minding things, when you're just like looking around, you can just create small little breaks. And then from that small breaks, you created larger breaks. So overzealous peeling may cause larger breaks. So you have to be really careful on what you want to see. Here's another photo. For tamponade selection. You can use your SF6 or air or your just normal gas for uncomplicated or moderate cases for TRD. You can use silicone oil for as long as you're sure that you're going to remove the silicone oil. Because sometimes by placing silicone oil in those very ischemic eyes, what you have is what we call silicone oil visual loss. Usually removal for these cases, it depends on how the patient is. If you have a one-eyed patient, silicone oil would be much better than rather have putting in the gas. Again, under tamponade in air and increases the redetachment risk for this patient. So you have to, when you use air, make sure that you're completely filled with these types of cases. Another good thing about this intra-op OCT, an intra-op OCT is a real-time visualization of your retina. You can look at it. You can look at areas where you have your epiretinal membranes. You can look at it during your surgery if you're not sure that you have a retinal break. That intra-op OCT is very useful now. Next, pharmacotherapy. As what Dr. Mancero was doing, intravitreal dexamethasone as post-tamponade for these cases is beneficial. You can also pair it with anti-VEGF for dual angiogenesis inflammation. And the only thing that can draw back is IOP spikes post-op. So monitor these cases. Again, so these are sample cases of your vitreous hemorrhage using a gauge 27 to 20,000 cuts. As you can see here, what you do is an anterior posterior traction, and then you can go into the retina. You can just suction off the hemorrhages lying on top of the retina. And then from here, you can have a small little details of how your epiretinal membranes are. So again, Make sure that you have a complete PVD. And then after removing all the blood, you can now stain the membranes and then try to peel it off. So you can see here, I'm using the gauge 27. You can really go closer to the retina. You can go for staining and then peel. Then after doing everything in peeling, you can now just put your tamponade. Again, I use gas over oil for these cases. So after which, patient as well. Again, here's a step-by-step procedure for TRDs. Again, you do a wide field assessment of the retina, make sure that you see most of the things. Do a complete 360 vitrectomy to relieve the anterior posterior traction for these cases. And then after you relieve the traction, you can now zoom in at the optic nerve area. Then high magnification of the nerve. If you have a plane, you can move in using an in and out technique. You can do a segmentation delamination. You can do a lift and shave technique. So make sure that when you're doing a lift and shave, you're just eating that tractional membrane and not damaging the retina. If you have areas of bleeders, you can use your cautery. You can press on your cutter, or you can just raise the IOP to backlight so that the bleeding will stop. Again, for minimal dissection, you can use your cutter, you can use your bimanuals, you can use your forceps for these cases. Again, after ending these cases, the choice of tamponade will be dependent on what your patient needs and how you are comfortable with your cases. So for these cases, I just use your gas for these cases. That should be it. So again, this is one of the last slides we can use for pre-op. You can use it 3 to 7 days. Instrumentation, any gauge would be better. You can use a gauge 25 or gauge 27. Then you can use your valve cannulas, chandelier light, membrane dissection, as stated earlier. For neovascularization, vessels, you can do a circumscribe and then before lifting in order for you to prevent bleeding. PRP, you can perform, as what I teach my fellows, you can perform PRP before you do your surgery or after you remove all of your fibrovascular membranes. Corticosteroids, again, you can use your dexamethasone implant. Tamponade, gas and silicone oil, it depends on your preference. It has to be tailored for each patient. And post-op, close follow-up and monitoring for these cases. And importantly, work with the team, with your cardiologist, endocrinologist, and you have to work with the team. And again, early intervention for complications should be a must. Again, so key takeaways, primary success will be from the bimanual, anti-VEGF and intraop CT. You have small gauges now, wide angles, 3Ds. You can have your dexamethasone implants. Then what's the next move? Real-time imaging to dominate proliferative robotics. It can be used. Again, remember in the world of TRDs, it's not just about traction. It's about knowing when to pull, when to peel, and then when to pray. So thank you, everyone. APVRS is in Manila in 2025. Again, December 12th, you can go here. So thank you very much. I'm Dr. Nasal again. Open for questions.
Thank you so much again, Dr. Carlo Nasol. So I'd like to open the floor for any questions with the lecture. Maybe, Doc Carlo, maybe as someone who just recently started private practice or after finishing training, maybe one of the questions would be how to best teach all the numerous techniques to potential new fellows. How do you, is it time to start them first with perhaps 3D surgery so that they can appreciate everything in greater detail first? Or how would you is there a change in how you teach retina surgery nowadays with the dawn of new technology?
Well, with the most of the kids now are gamers, so with the 3D, with the early adopters of video games, most of the fellows now are more prone to develop better 3D hands than the previous generation. So between 3D and what do you call it? And the standard operating microscope, I would suggest that they go first with the traditional since they're not used to it, and then they shift to 3D. For newer consultants who have underwent training before, 3D will be something new to them. For the techniques, I just go first with the standard, how to do the basic step-by-step vitrectomy, and then go with the more complex case at the end. That's it.
Thank you for your input, Dr. Carlo. Any other questions?
John, I'm totally agree with Dr. Carlo. I think that now the young generations are more friendly with this kind of technology. Vitrectomy is visualization. I repeat, vitrectomy is visualization, not only maneuvers inside the vitreous cavity. And if you have a good visualization with 3D surgery, it's absolutely different and absolutely easier to teach, to learn, to understand what's going on with visualization. And this kind of situation with non-contact wide field or chandelier by now, it's easier when we began 25 or 30 years ago with analogical visualization, with direct contact lenses. And I think that you are in a very spring area of visualization. Now we are in digital area, have drugs, and I totally agree with Carlo that the fellows are gamers and the residents are gamers, and you can see how easy they incorporate in their practice the 3D viewing and the digital surgery. Totally agree with Carlo. Thank you, Dr. Marcelo. My pleasure, Carlo. My pleasure.
Any other questions from the panel?
No, I think if not, I think we'll move on to Dr. Noor's lecture also.
Thank you. I will try again because I think this one, share. Although we listened very nice lectures. Sorry. Okay, I think you can see my screen now.
Yes, ma'am.
Perfect, Noor.
Thank you. Sorry, I had to make some settings. So beautiful lectures, beautiful surgeries, nothing much to say left actually. I enjoyed your talks very much. So I just wanted to emphasize that diabetes is really a huge problem of the world in this specific day, because we have to remember that it is the most important reason for blindness in the adult age. And now we can read the data that 1 in 9 adults has diabetes, and even in 2050 it will be 1 in 8. So it is a bit scary numbers, that there are lots of patients. So we should do some maybe imaging to prevent the disease and prevent the retinopathy, because we know that at least 5% of these eyes will require laser or vitrectomy. So I agree also that we are in a lucky stage, because we have in the last 2 decades, we have lots of tremendous progression in the equipment, surgical techniques and experiences. So we are lucky even with the 3D now, and also intraoperative OCT, if possible, will guide us during the surgery. Although it has been all covered actually, but I have to also talk about the small gauge vitrectomy, because it's also a progress that we started to use small gauge vitrectomy in around 2005, but now they had problems, and now even with the cutting edge probe edge technology, we can work very close to the retina. But it is the small gauge that it has been also emphasized. The 27 is the best. So I have, but unfortunately we cannot find 27 every time in every OR. Unfortunately, especially you have to change your ORs. So this is a video of a diabetic reaction detachment with 25 cutter and 23 for the young colleagues. 23 gauge is not small enough actually, so you can cause some maybe tears inadvertently. So 27 is the best, but this is a 25 cutter. We start the vitrectomy. As you can see, there are lots of membranes, mostly fibrotic, not so fresh neovascular. So it is practically segmentation and then delamination. As long as you can feel you safe enough with the unimanual maneuvers. We have to always see the retina underneath, or at least the plane that we are moving, cutting our membranes during these maneuvers. And at some point in the stage, especially in the periphery, sometimes it's not easy to delaminate with the cutter, and we have to also be familiar with the bimanual techniques, I believe. It should be also in the armamentarium, and it can be forceps, scissors, or even a needle, as with the experience of the surgeon. So, and also I'd like to talk about the anti-VEGFs. I think it's also a game changer, one of the game changer in the retinal practice. But regarding the traction retinal detachments, we prefer it in the anterior segment neovascularization eyes, or severe TRD with active neovascularizations, and maybe in some eyes with poor control and no laser preoperatively. It can be an option. Also, the timing of this is really important, because in diabetic patients, we do the injections, but the patient, some of the medical problems, we cannot do the surgery on time. So we have to be prepared for that. And also Crunch syndrome, I'd like to remind. It is a progression to TRD following intravitreal anti-VEGF injection, and there's a sudden visual loss and abnormally increased contraction, very tight adhesion of the membranes. And it is incidence is not determined fully, but duration until PPV is important, and especially in severe DRP eyes with fibrosis, if it is prominent, we have to be careful about that. And high dose anti-VEGFs should be abandoned. Let's say we should prefer that. So I'd like to present a case of mine. As you see here, is a young patient, type 1 diabetes with poor control, not so cooperative. Also, I must say, vision was 0.05. So I did the injection, and then in the third day I planned the surgery, but he could have the surgery on the fifth day. So as you can see in the right screen, it is the intraoperative photo, and he presented with hand motion with a dramatic decrease in vision in 5 days. So this is a surgery of this patient with a 23 gauge vitrectomy. As we all know, we have to cut the vitreous between the periphery and the membranes, in this case, as much as possible to prevent traction in the peripheral area. And I always use triamcinolone, as Marcelo said. I like it because we can, but we have to clean it also. I use diluted forms. And in this one, sometimes I prefer to, even you can use, especially young colleagues, dual dyes, or to stain the membrane. Actually, it is also a tool that we can use sometimes if we prefer. As you can see, I start with the unimanual with the forceps. Like Sanjit also mentioned, to go for the optic disc if possible at the start. And luckily, it was really with a very careful traction pulling with the forceps, I could delaminate it from the optic disc. But at some point in the temporal area, it was unusually, very unusual contraction and disintegration of the membrane to the retina, as you can see in the mobile retina. So I have to go with the bimanual techniques. With the bimanual techniques, my young colleagues also should be used to, sometimes with the non-dominant hand, we can pull the retina much. So we have to be careful about doing bimanual maneuvers to stabilize our hands and not to pull too much. Maybe we can also make a tear underneath that retina sometimes, because that's why maybe a bimanual also we have to be experienced in time. But after that, using the scissors, like a blunt dissection, cutting when necessary, when we lift the membrane, and continue with the probe. So mixing all those techniques, whatever is necessary, sometimes is needed during the diabetic vitrectomies, and that is what makes it, I think, appealing also. I always do the laser intraoperatively, especially starting from the peripheral part with an indentation, because I think it's also nice because we cannot do it after the surgery. It's not possible to do as far as periphery. It's very difficult. So the anti-VEGF, we can say that it worked really nice, and there is no bleeding, much bleeding in this case. There is subretinal fluid, but I didn't want to peel any ILM in this setting. So, and the patient was a mobile young person. He wanted the silicone oil before the surgery. So we can say that in 3 months and 4 months, there's a shallow subretinal fluid under the macula. The vision was 0.2, and I removed the silicone. It's the 4th month, I think this is. So, and in this setting, it was much easier and safer to peel the ILM, and we can say that it is even more contracted in time, and there is a contracted membrane in the superior arcade. So peeling I'd like to fasten this video. Peeling the ILM, it was not so complicated, and releasing this traction in the vascular arcade unimanually is possible, and it ended with air. And the vision acuity remained like in the 50 years, still 0.2 was stable. So as a take-home message, I agree with all my colleagues that success rates of PPV for tractional retinal detachment increase a lot because of the progressions in equipments and techniques. Timely operation is important, and which needs also for the surgeon the caution and the patience and the ideal equipments at hand, and to be ready for all the surprises during the surgery. And also it is a lifelong disease, and it should be a teamwork, including us, the patient, and also the internal medicine, and even the family, and the follow-up and control of any complications afterwards is also important for the vision and the integrity of the eye. I thank you for this, again, kind invitation and opportunity. And also, I'd like to invite you to the upcoming EVRS meeting in Cancun in the 12th of November. If possible, we'd like to see you there. And if not, maybe you can also join online. Thank you. I stop my sharing.
Thank you, Dr. Noor. Excellent talk, excellent surgical videos, and excellent tips. I think all of us have learned a lot from this session, and the take-home points of all the speakers were most very collaborative and the similar this ones that we learned today. Dr. Noor, Dr. Marcelo, I want to ask, how do you decide in a case as to where you want to do the ILM peel or where you want to leave it? Like Dr. Noor showed her last case where she left it and it was easier to do the ILM peeling with the SOR. So any tips about where you want to remove it during the first surgery and where you leave it to tackle with it later?
Noor?
Okay, thank you. Thank you for the question. Actually, in usual diabetic traction detachments, I usually don't peel ILM. It's not as a must for me. But if I see, if it is comfortable for me, if not so much bleeding, and if I can see that the ILM is really wrinkled and doing some traction on the retina, then I can peel it. Of course, intraoperative OCT, if we have it at hand, it will be also a nice tool to decide maybe. And in this case, for example, there was really a very huge traction, and I knew that I would already give some silicone oil, and maybe if the subretinal fluid didn't leave and didn't stay and maybe absorbed much more, I could have left it in the second silicone oil removal. So it is not my first thing to peel the ILM. If there is a lot of traction, and I believe that it affects the vision of the eye and also like epiretinal membrane, with epiretinal membrane, I would like to peel it, or else I leave. Thank you.
Yes, I'm agreeing with Noor, but it depends on the case. You have to watch the case of the case. As I saw, it's monocular patient, it's a PDR1 patient, monocular patient, good follow-up, bad follow-up, the age of the patient, the stage of the PDR. And I think in some situations when you have a very difficult to peel ILM, the perfluorocarbon liquid, is a very nice tool to use and to control the peeling, to peel under the PFO because it's like you have viscoelastic in the anterior chamber, and you can use it to control the maneuvers in some time when you lost, because the ILM in the diabetic patient is different in non-diabetic patients, but also as a tip and tricks, use perfluorocarbon sometimes to pit the ILM in this kind of elastic or adherent ILM patients in PDR.
I agree. And also, if there is some cyst edema in the center, of course, fovea sparing we prefer in diabetic also, not touching the fovea with ILM.
Total agree. You can do macular hole in that situation.
Yes.
Yeah, totally agree. It's necessary.
Yes.
Any other questions from the panel? Okay, if not, then we'll hand over to the next session. Thank you, Dr. Noor, Dr. Marcelo, Dr. Carlo, Dr. Sangeet, all our panelists, Dr. Jom and Dr. Ruchir. Thank you so much. Thank you, Vaibhav, for giving us this opportunity and this amazing learning that we have, and which is going to continue. So over to the next session.
Okay. Thank you.
Thank you.
Thank you so much, and hope to see you soon in person.
Thank you.
Take care. Take care. Thank you so much. Have a nice day.
Thanks, Day. Thank you.
Thank you, John. That was a great previous session. So let's move on to the next session, that is the Ocular Trauma Masterclass. It is my pleasure to introduce the first speaker, Dr. Faisal Fayed. He is the co-founder, chairman of the Department of Ophthalmology and a senior vitreoretinal surgeon in the Jordan Hospital at Amman. He started his career in the Ministry of Health in the King Hussein Medical City and Jordan University, and he has multiple publications and international speeches, and has also trained a lot of young vitreoretinal surgeons. So, Dr. Fayed, the stage is yours, and we're really looking forward to your talk on severe trauma in children. You're still muted, Dr. Fayed. Yeah.
Thank you. Thank you for the invitation. Yeah. Once again, thank you for the invitation. I'm happy to be here. I hope that our colleagues are watching what kind of a trauma we can treat and about the severity of trauma. I'm talking first about a boy, 7 years old boy, blunt football trauma. Then soccer or football is not always fun, but sometimes there are complications. Let's see, this is the case. This is how the patient presented to me. You can see there is a macular hole, there is no PVD. And here I'm inducing PVD. There is this is large macular hole, peeling, but I thought that it was the posterior hyaloid. Draining, you see, I thought it was posterior hyaloid, but it was not actually. I peeled.
Dr. Fayed, I think it's not visible, at least to me, the video.
Yeah, they are not visible. Sorry.
Yeah.
Dr. Faisal, I think you're sharing. You're not sharing this. You're not. That's it. Now
it's visible. Yeah.
Okay,
thank you.
Let's go back. Okay. Let's go back. Yeah. Okay. This is the case. This is soccer. As you can see, there is total retinal detachment. There is peripheral large retinal break, and you can see the large macular hole. Here I am peeling I thought it was posterior hyaloid, but it turned out to be the ILM. And this is how I repair the macular hole and peeling the ILM under heavy liquids, making multi-layer flaps covering entirely the macular hole, then going anteriorly, inducing PVD. And you can see here, I freed the incarcerated vitreous from the infusing cannula, sparing the lens, of course. And this is the avulsed retina laser. In this case, I use silicone oil since he is a little boy, and the patient did very well. I escaped this case. This is 7 years old girl with penetrating injury. You can see here the penetrating injury. You can see I'm doing temporal approach vitrectomy in this case because the retina and the sclera are damaged superiorly. So you can go wherever you feel comfortable and where is more convenient to do the surgery. There is, you can see here strands very anteriorly of the vitreous, almost touching the lens, and you have to make your own decision to do complete surgery, successful surgery, or spare the lens, or you have to sacrifice the lens and to do complete surgery. In my case, this is, I started posteriorly, and can see here, this is how the retina looks like. There is a clot. You don't know where the retina is damaged. And here you see there is a new vascular proliferation coming from outside inside the vitreous because the surgery was late, but we could save the eye in this case. Here I decided to do ILM since I could not do chorioretinectomy. Is very close to the central vision, enlarging the ILM peeling. And this is how it looks like. And you can see this is another case, single-eyed, 8 years old boy fall down 2 weeks before presentation on construction, iron rod with severe globe laceration of his only eye. The first eye was lost due to RTA with optic atrophy. And this is at presentation how this little boy looked like. Total retinal detachment, PVR. And this is, you could not leave the boy alone. His only eye, and you can see there are posterior retinal breaks, peripheral incarceration, PVR, plot underneath the retina. Here I joined the tears together, air exchange, in order to know where I have to cut the retina to see where the incarceration is. Once you flat posterior retina, you understand, of course, under heavy liquids in order to keep the retina in place. And here I succeeded to flatten the retina. The patient was referred 2 months later with redetachment with this temporal hole with subretinal fibrosis. And actually, it was convenient, the presence of the hole, since I could peel through this hole, the subretinal fibrosis. Actually, it took me more time to clean the surface of the retina from the induced clot over the surface than the surgery itself. And here, of course, you can't leave the clot over the retina. Otherwise, you'll have severe PVR. You can see all the peripheral retina is flat. There is no problem. Since it's a little bit far from the fovea, endolaser was enough. And the retina kept flat, and the patient is going to school now. 4-year-old boy fell down while running with a car keys in his hand. And this is how he presented with severe hypotony. He was sutured in other country. I referred here. Here I'm doing lensectomy. Of course, in such cases, you have to peel the posterior hyaloid as well. Otherwise, it's where PVR will grow. Here I'm taking some membrane from anterior vitreous, and you can see this is very likely it's inflammatory membrane, severe inflammatory membrane, and this is how the retina looks like under this membrane, injected some heavy liquids. Once you see a fold, it means that there is incarceration. There is a fold, then there is incarceration. You can see there is a PVR with a spatula. I just peel the PVR membrane anteriorly. You can see here in such case, there is no room to peel anteriorly. You have to cut the retina. Very likely the retina is foreshortened as well, cleaning the subretinal space. And you see here the retina, trying to rotate the retina to put it in place. And here the patient, as the previous case, was sent back, I think, 10 weeks after surgery, and they thought that it was recurrent retinal detachment. No, this is subsilicon oil proliferation with macular fold. You can see it peels in one sheet. This is subretinal fibrosis, proliferation, I would say. And you see here, it's extending as much as I peel this membrane. And this is how the retina looks like and flat. I was asked just to finish in 7 minutes. So I go to conclusion. The final result, final surgical and functional outcome depends on the severity of initial injury and the primary kind of primary repair, timing of the referral for further management, the recent use of methotrexate and other drugs has encouraging results and might help in prevention of PVR. Despite the advancement in vitreoretinal surgery, there are cases, unfortunately, are beyond repair. And thank you very much.
Thank you, Dr. Faisal, for a beautiful talk. I think pediatric retina itself is a very challenging field, surgical field, and when you add trauma to that mix, it becomes very complex. So your talk beautifully demonstrated in different type of cases how well pediatric ocular trauma can be managed. I have a question. When you talk about timing, because you mentioned that couple of times in your talk as well, there is a debate between early and delayed vitrectomy in pediatric trauma. So when, according to you, is your personal choice, when would you intervene, and what are the factors that you look for to intervene early versus late?
ASAP, I would intervene in all kind of trauma as soon as possible. You know, the classical teaching was 2 weeks, wait for 2 weeks. There is nonsense in waiting 2 weeks. We were not expert in vitreoretinal surgery, and we were waiting for PVD to by its own. It comes by its own, but currently, I mean, there is no point at all of waiting for 2 weeks or 10 days or 7 days. As soon as there is severe retinal trauma, you have to do primary repair. Sometimes, I'm not talking all the time. Sometimes I do all surgeries once I do the primary repair. But unfortunately, my place is tertiary referral place, and we have referrals from surrounding countries, and sometimes they come after 1 month, 2 months, 8 weeks. And those cases that I showed, some of them in the classical teaching, we were not ready to do this surgery. We were not doing them anymore. But currently we do them. Of course, we do them. I prefer to intervene as early as I can. Should I do the surgery, I mean, in 2 stages, I would do it within, I call it the magic 100 hours. I mean, within 3-4 days. Primary repair first day, 3-4 days. After the primary repair, I go for the second surgery.
Okay. And when you're talking about PVD induction, do you have any tips for younger surgeons? Because in pediatric cases, PVD induction is very difficult. So what do you follow to get an easier plane, and how to induce PVD in these cases?
You know, really, PVD induction is not difficult even in pediatric cases. It's difficult once you have total retinal detachment and the retina is mobile. That is the challenge. But otherwise, it's not difficult at all. If you have, attached retina or fixed fold, I mean, if there are fixed fold, it means that there is PVD. The only challenge really, once there is, mobile retina, otherwise it's normal. I induce PVD even in pediatric cases like Coast disease and others. So I don't find it difficult. Just they go use PVD assisted triamcinolone, as was mentioned by Marcelo a while ago, that he uses in all his diabetic patients, just like myself, because sometimes you feel that you induced PVD, but you did not.
Yeah.
And the only thing that you are sure that you induced PVD is once you use triamcinolone. The other trick in pediatric cases, you think sometimes that you induced PVD, but you did not. And the only thing that you are 100% sure that you do ILM peeling. Once you do ILM peeling, you are 100% that you induced PVD, because if they peel the ILM, it means that there is nothing on top of it.
Yeah. That's an excellent tip. Thank you, Dr. Faisal. Any of the panelists have any other questions, please, before we proceed to the next talk?
Yeah, I just wanted to ask one question. Excellent presentation, Dr. Faisal. I just wanted to ask, like in adult trauma, we have an algorithm that sometimes when the patient is PL negative and there is no visual prognosis, so except the primary repair, we do not do any definitive surgery. So in case of children, do you consider this, or we operate all the patients, even PL negative, because we have seen some surprising results in these patients?
I really rarely do no light perception cases. I did it, and I was surprised. Actually, he was not a child, adult, relatively. I mean, in his late teens, early 20s. And I was surprised from the functional result. It was excellent. You know, we have to weigh out the benefits, or if the patient presented to you after a while with phthitic eye, with no light perception, there is no point of doing the surgery.
But sometimes in children, that reliability is not there for PL negative. So in those cases.
Yes, but usually if there is light perception, I usually do surgery. Usually I do surgery. Any eye with light perception, I do surgery. I can't claim that I succeed all the times, but often I succeed. And, you know, I mean, even having some success in such cases, I think it's a big gain. I mean, not just for the patient, for the community as well.
Yes.
Any other questions?
I have a question. First of all, great talk, Dr. Faisal. In your talk, you mentioned agents which delay PVR, like methotrexate. Can you talk about your experience regarding such agents?
Really, in preventing PVR, I mean, I don't have experience. I read it in literature, but I don't have personal experience in preventing PVR. But I think it does not depend on chemical agents as well. Sometimes extensive surgery and clean surgery, it plays a big role in preventing PVR. So it's not about chemicals that preventing PVR. It depends how well you do your surgery, how complete you do vitrectomy, how complete you do your peeling. I think this is play a big role in preventing PVR.
Can I make a comment?
Of course, Gianpaolo, you're welcome always.
Hello, Faisal. I just want to point out for those who haven't noticed, you had a case of perforating injury. I think it was a young girl, 7-year-old girl.
Yes, yes.
Yeah, the importance of not removing that plug. You left that plug in place. So the temptation there could have been removing that fibrous tissue, and obviously that would have been a disaster. So you left it in place and just cleaned around it. And that obviously was the right thing to do, but maybe not everybody had noticed that. I just want to bring everybody's attention to that.
Thank you. This extends actually from outside the eye, inside the eye. It was perforating, and this proliferation is not coming just from inside the eye, it's coming from outside the eye.
Thank you.
Thank you.
So I
Thank
have a
you,
question
Dr.
for Dr. Faisal. What is your take on traumatic macular holes? When do you intervene?
This is a good question. I wait really, I mean, up to 2-3 months. I don't do them after 1 month. I have recently a case he was completely closed after maybe 10 weeks after the surgery. Gianpaolo, what do you think?
I agree. I've had several young men and women having traumatic macular holes. Those are the ones that generally can close on their own. So the best visual outcome is generally doing nothing and waiting to see if they close on their own, and the results are better than with surgery.
Yeah, thank you.
Thank you all. Thank you. Thank you.
Thank you, Dr. Faisal. I'll pass the mic on to Dr. Avadesh for the next speaker.
Thank you, Vaibhav, for this wonderful opportunity. So next talk is by Dr. Hussain, who is a senior consultant ophthalmologist, and he specializes in cataract and vitreoretinal surgery. And he is currently practicing at the View Hospital in Doha. And he previously held substantive consultant post in UK NHS and in private sector. He is a vitro-retina consultant of great repute, and he completed his medical retina and VR fellowship at Southampton University Hospital NHS Foundation and Manchester Royal Eye Hospital. And he has served as a medical lead at PPG and remains an international speaker on advanced and innovative surgical techniques with a clinical focus on macula, vitreous, and retina surgery. And today he is talking to us on management of ocular trauma in war victims, a second case series from View Hospital. Over to Dr. Hussain.
Thanks for the invitation. Can you hear me?
Yeah, we can.
Great. So I'm gonna share my screen now. Please let me know if you are able to. Okay, so this is share screen and share it now. Are you able to see the presentation now?
Yes.
Perfect.
Yes, we can.
Perfect. I mean, I would like to thank the organizers and all the people who are behind such a great I would call it an eye ocular surgery day. My presentation is as part, as you can see, of an ocular trauma session, and I feel privileged to be able to be given this opportunity and to share the the plateau with great surgeons like the group that is going to be presenting today. So I have. I'm not sure if I've been lucky or not, but we here in Doha, during the war in Gaza, we have been fortunate to help some of the war victims, and we have managed to receive a good number of cases at the beginning of the conflict. As we all know, the conflict is there since for the last 2 years, but I think we are lucky today because there has been an agreement of ceasefire, and I hope that we very soon will be able to offer some aid to people inside. As any conflict, it does lead to widespread devastation, high civilian toll, and loads of medical challenges. Here, a combination of the Ministry of Public Health, Hamad Medical Corporation, and also the View Hospital, we received an overall of 1,923 OPD cases, and 211 of them were seen by ophthalmology. We received most of the cases were ocular trauma cases, and we managed to get 34 trauma cases operated on with 211 non-ophthalmic surgeries. It was a multidisciplinary approach, as you know, between ophthalmology, neurology, neurosurgery, and I would like to highlight a couple of cases that I have managed in, between those 34 cases. What we found that most of the cases were a combination injury, a blast injury, a foreign body penetration, chemical burns. Our immediate concern was to prevent an infection because there was a delay in presentation, and to try to preserve some remaining vision, but at the same time thinking about the ocular trauma and the long-term impact. The visual prognosis in most of the cases was, I would say, bad, but we have managed to save vision in a good number of cases because their trauma was trivial, but we had also significant traumas that led to, as you will see in the following cases. I would like to talk about two cases. One of them is he was a fourth year medical student, but I know that he moved to Egypt and he finished his medical school because this has happened 2 years ago. He had the left eye blast facial trauma. He was injured while attempting to figure out what happened to his younger brother after an explosion. He came to me with severe vision impairment, and there was a high risk for long-term complications. And the second case is a shrapnel injury in a mother, 29-year-old female, moving to a safe zone, shrapnel injury to the right eye, and had from a quadcopter drone strike. She was wounded while seeking safety for herself and her children. Now, I'm going to start by the first case. And as you can see, this guy came with that severe facial trauma. And he was first managed by the MaxFax primary performed at the Dexmod French Field Hospital in Egypt. And he came with left eye perception of light vision, hypotony, no fundal view, vitreous hemorrhage, but flat retina on the B scan. He had his primary traumatic cataract removal and intraocular lens insertion performed by one of the French professors in Egypt, and then he was moved to Doha. As you can see, the extent of the facial fractures and the intracranial involvement. Being a medical student, I was willing, or I was like hoping that I can save some sight because the retina was flat, but I was not thinking what would be the situation when I start removing the vitreous hemorrhage. In the second case, which I'll go later, this is the lady arrived with right eye hand motion vision, traumatic cataract, vitreous bleed. There was no evidence of intraocular foreign body, and there was like query retinal detachment. We didn't know if it's a detachment or the posterior vitreous detachment with the bleed. We did a CT scan, which revealed an intracranial foreign body trajectory and the extent of the ocular damage, but there was no intraocular foreign body seen on the CT scan. We tried to look if there is an entry site. We managed to see, but we were not sure where is or what happened to the eye. And I will start with the first case, which is the fourth year medical student. So you go into the back of the eye, you look, you try to figure out what's going on behind that vitreous hemorrhage. I started by clearing as much vitreous as possible behind this secondary IOL inserted. And I was, as I said, hoping that I'm going to have some vision back. So after clearing of the posterior capsule, clearing of all what we call it the retro-lenticular gel, and when you look at the picture, I have never seen such a picture in my life. But like what I was thinking, well, this should be like an extensive or a massive sclerotiria, chorioretinitis sclerotiria. When you see this, you just feel, well, I mean, we managed to get the vitreous hemorrhage cleared, but the visual prognosis is very, very, very poor. So I have an intraoperative OCT, and I wanted to show you that when you do look at this, you can see the characteristic or the features of what we call it the sclerotiria, where the rupture of the chorioretina and the retina led to the massive bleed, and what we are dealing with now is just the residual pigmentary changes of the RPE. So this case was managed successfully. He still, he didn't have any future retinal detachment after that, but unfortunately, this case represents, like the impact of such a blast injury on such an individual, where no more vision could be retrieved, but it's like it tells you the extent of damage that you could get even without having what we call it an penetrating injury. Now, for the second case, I managed to deal with a traumatic cataract, and I went into the back of the eye, and again, dealing with a vitreous hemorrhage, it seems to be like you figure out that it's combined with retinal detachment. I learned. I was honored and lucky to have Dr. Gianpaolo Gini as my mentor, surgical mentor, back in Southampton University Hospital. And I learned from him that we need to do complete surgery, but at the same time, if you can fail well, it would be good. So I knew that this patient will have PVR in the future. So what I did in the first surgery is clear the vitreous hemorrhage, no peeling of PVR, because I knew I would go back into the back of the eye. I dealt with the superior retina. It seems that the foreign body did not go through the eye. The foreign body went tangentially across the eye globe and went into the intracranial cavity, but it was not in the eye, and that detachment is just from the friction between the foreign body. Now, this patient, as expected, came back with, I'll go back here. So came back with, this is, no, let's go back here. So this lady, yes, after the first surgery, So I was expecting that she's going to come back with a re-retinal detachment, and this is what happened. So I had to go into the back of the eye again and deal with the PVR because it became more mature and easy to deal with. So went again for a second surgery, removed the oil, peeled those, tried to deal with those star folds the way we all learned, minimal peeling, get the retina back, and do the, what we call it, the air test, which if the retina goes flat under air, in that case, no further peeling would be necessary. And I dealt with some of the areas that I had to release and back again into a 5,000 oil. I mean, I was lucky. The patient is still lucky because now it's about more than a year after the second surgery. This was 1 week post-operatively, and this was 3 months post the second operation. The lady is still having such a flat retina under oil. She insisted, many times for me to remove the oil, but I decided not to go ahead. Now, and this is how her retina is still, because she is now being referred to the public sector, but I'm in touch with my colleagues about her follow-ups. Now, go back to this case. The peculiar thing about this case is the following, that we had an intracranial foreign body, as you can see here, but we didn't know how it went into the intracranial cavity. But by looking carefully at the imaging, we found that the entry was 1 centimeter temporal to the temporal edge of the greater sphenoid. So this is the sphenoid bone, so it was temporally. It went tangentially, did touch the globe from, within the cone, went 1 centimeter temporal to the temporal edge of the superior orbital fissure. It did its trajectory, as you can see in this image, in the temporal lobe, and it lodged in the posterior cranial fossa, blending into the most lateral aspect of the transverse sinus. So this patient was lucky. She's right eye dominant, and this is her right temporal lobe. If this happened in the other eye, she would ended up with aphasia. And I think, this is also another peculiar situation where patients could be lucky even with the presence of an intraocular injury and also the presence of an intracranial foreign body after such an injury. In general, in addition to ophthalmology, yes, we deal with the eye, but the psychological impact and the support that these patients need is huge. The post-traumatic stress disorder, the adaptation strategies, the peer support, and the family education. I think dealing with trauma in war victims is multifactorial and multidisciplinary. It's time sensitive, especially with the absence of resources and the high infection risk. And in general, it needs a huge collaboration, timely intervention, and ongoing management. I hope after the ceasefire in Gaza that aid will start going into the Gaza Strip, and I hope and I'm asking now all my VR colleagues that at some stage in the near future there will be a need for an influx of VR surgeons to help with all the trauma that is being handled. And I hope that we very soon will be able to help those patients in need. Thank you very much, Pan Ophthalmologica.
Thank you.
Thank you, Dr. Hussain. That was a wonderful presentation and overview about war injuries, which are unusual and not seen very commonly in a civilian setup. But now we have seen in recent wars that even the casualties, they are the civilian population, which have to be handled by the doctors who are doing their surgeries. So earlier, if we look about the Indian data, there is a paper I came through wherein they have studied 777 eyes in pallet injuries. That was a sort of civilian conflict which happened in 2016. There they have shown that almost three-fourths of the patients, they were not very lucky. And despite of very, very emergent management, the outcome was counting fingers in most of the cases. And also the previous war doctrine of stay and play has now changed to scoop and scoot, so that you give tertiary care to these the people who are injured in the war. But we should always keep in mind the primary care which we provide. We should always train our budding surgeons on the primary care, which would be the giving priority to life, limb, and then sight, ATLS, and algorithm-based approach to these patients, so that we do not forget the serious injuries which can kill these patients. Any other questions or comments from the panelists, please?
Hi, Doctor. Thank you for your lecture. Do you,
Thank you.
for people who want to, for surgeons who want to tackle complex cases such as this, do you have any um, advice or tips on how to best approach consultations with the patients? Do you strictly refer the patients for the psychological aspect? How do you advise them on the prognostication of vision?
I think, a war victim is a war victim, or even an ocular trauma case is always difficult to manage, because you manage the eye, but you've got like a human being behind this, and you're talking about vision. So you talk about something precious. I think it's good to handle the situation in a multidisciplinary approach. I think the psychological support should be, provided at an early stage, because we I mean, some of us, that we might be experts in being able to get patients to talk, but sometimes you've got like a guarded appearance, somebody who's just trying to keep, their strength. So especially when it comes to war victims, I think psychological support is vital at the beginning. I think even with that, and knowing that those patients, they need hope, but managing their expectations is also as important. So I think even with that, do not put high expectations, because usually a trauma case is a trauma case. They end up with an average of 3 to 4 surgeries, if not more than that. So try to support them psychologically, but be cautious when it comes to giving them high expectations, and managing their visual sort of aspirations after surgeries. So this is how I managed to deal with it, involving other colleagues as well. Dealing with it in a multidisciplinary approach is vital. So keep the circle on, but managing expectations and having the psychological support at an early stage is vital.
Thank you, doctor. Thank you for your advice.
Any other questions or comments? If not, thank you for that wonderful talk, sir. Now I would hand over to Dr. Anugraha to take the proceedings further. Thank you.
Hi, good evening. I'm Dr. Anugraha Prasanna from Mahatma Eye Hospital, Trichy, Tamil Nadu. I'm a veterinary surgeon. It's an honor and privilege to be here today in Pan Ophthalmologica. Thank you, Dr. Vaibhav Sethi, sir. So it's an honor to introduce our next speaker, Professor Dr. Nesreen Abro. She's a professor of ophthalmology, veterinary surgeon, Department of Ophthalmology, Fatoma Bourguiba University Hospital. She's also a faculty of medicine, University of Monastir, Tunisia. She has multiple publications in peer-reviewed journals, ocular immunology and inflammation. She has systematic reviews and case-based studies on retinal vasculitis, uveitis, vitreous hemorrhage, and a lot of work on ocular manifestations of infectious disease. So she's also been invited as a speaker at the International Ophthalmology Congress. Over to Dr. Professor Nesreen Abro for her talk on traumatic endophthalmitis, intraocular foreign body, retinal detachment. What else? Over to you, Dr. Nesreen.
Thank you very much. Hello, everybody. I'm very happy to be with you today, and thank you for the organizer for this invitation. And also, I want to congratulate all my colleagues for their presentation. I am sharing my screen. Could you see my screen, please?
Yes, it's visible.
Okay. So I would like to share with you a case of post-traumatic endophthalmitis related to intraocular foreign body and complicated by retinal detachment. So the case is about a 43-year-old male patient who presented with left open globe injury with projection of non-metallic intraocular foreign body 1 week earlier. So at presentation, the patient had the vision limited to light perception. There was anterior chamber hypopion and cyclitic membrane. There was also a post-traumatic cataract and a dense vitritis. BScan ultrasonography shows the dense vitritis, and CT scan show the intraocular foreign body. So the diagnosis of post-traumatic endophthalmitis with retained intraocular foreign body was made. And the first challenge in the management of this patient is the treatment of endophthalmitis. So of course, we have to close the wound as soon as possible and to treat the infection. But the question here is when to go for vitrectomy and when to remove the intraocular foreign body. As you know, the dilemma of early or late vitrectomy in the setting of retained intraocular foreign body remains challenging and controversial, and the benefits of early and immediate removal of intraocular foreign body is to remove the presumed cause of infection, to remove inflammatory debris, to take some samples for microbiologic analysis, and also to decrease the rate of PVR in this eye. But the surgery might be difficult, and the visualization is often problematic in this situation. So we can opt for delayed surgery or a sequential surgery. We go for globe repair, intravitreal and systemic antibiotics to improve the control of inflammation and to enhance visualization. Then we will go for a delayed surgery and removal of intraocular foreign body with a higher risk in these cases, in this option, a higher risk of retinal detachment and PVR. So for our patient, we opted for the second option. A primary repair of the wound was done, and intravitreal injection of antibiotics, vancomycin and ceftazidime was done also, along with double systemic antibiotics. On follow-up, the patient 1 week later presented with improved anterior chamber inflammation, but he developed a total retinal detachment. So we decided to go for surgery. Of course, it was a combined surgery. And in these cases with a soft eye, I like to use anterior chamber maintainer to pressurize the eye. Also, in this situation, the most difficult, I think, step is to put the infusion line. So I keep the anterior chamber maintainer to pressurize the eye and to put the first sclerotomy and to put the infusion line. Also, we have to check the infusion line position before putting on the infusion, as you see. Then we go for vitrectomy, central vitrectomy to enhance visualization. As you see, there was a total retinal detachment, severe PVR, and there was also a large inferior break, as you see. And we go to peripheral vitrectomy to shaving. And during the vitrectomy, despite the checking of the infusion line displaced in the subretinal space. I try to free the sclerotomy. Here we see that the foreign body passed through the break in the subretinal space. So I decided to remove the infusion line and to put another one in at 12 o'clock to avoid any incarceration of the retina in the inferior retina. Here we're going to we go to the posterior segment and we will go to remove the foreign body. I will use forceps to remove the foreign body from the subretinal space to put it on the retina. Then I use MVR blade to create sclerotomy and using forceps 18 gauge foreign body forceps to extract this large foreign body as you see. After that, of course, we will suture our sclerotomy and going now to tackling this PVR. Of course, in these cases, we have to peel as much as possible the membrane, the epiretinal membrane. We can use either bimanual or unimanual surgery. I like to use unimanual surgery, and of course, we have to be gentle in peeling the ILM, the PVR, sorry, and to peel beginning in the center of star fold here. This is the peeling of membrane, which has to be as large as possible and as complete as possible, because I think there is a mature PVR in these cases. Of course, we have to stain and restain and go to, here I'm using a flat lens to peel the ILM and the posterior pole. And of course, in PVR cases, we have also to peel as large as possible in the posterior pole until the arcade to avoid any reproliferation. After that, we have to inject PFCL to stabilize the retina, of course. And in this situation, I decided to go for 360 retinectomy after doing endodiathermy to avoid any bleeding. Here I increase the level of PFCL. Then I will go for 360 laser and direct PFCL silicone oil exchange. And this is sorry, this is the post-operative fundus photographs. This is 6 months post-operatively. The retina was attached under silicone oil. And now I'm following this patient for more than 2 years. The visual acuity is 0.1. The retina is attached under silicone oil, but the patient has a low IUP, has hypotony under silicone oil. So I think the second challenge in managing these cases is the management of complication of PVR surgery-related complication, which might be managed. And the most important complication is reproliferation, redetachment, and also postoperative hypotony. I think it's the most challenging complication. As you know, this hypotony might be related to ciliary body traction, to cyclitic membrane, to ciliary body ischemia, which will lead to aqueous production, decrease in aqueous production, but also large retinectomy, excessively large retinectomy might lead to hypotony by increasing the avoscleral outflow. So the most challenging, I think, is dealing with hypotony, with persistent hypotony. We have some option, but I think these options are ineffective in almost all of cases. For my patient, I decide to have long-term silicone oil component. I didn't decide to remove the silicone oil. To conclude, the management of post-traumatic endophthalmitis with retained intraocular foreign body remains a challenging and controversial issue. And I think we have always the option to immediate globe repair and go for one surgery or a sequential treatment. And in my opinion, the persistent postoperative hypotony is the most challenging complication of these cases. Thank you for your attention.
That was a wonderful talk by Dr. Nesrin, well covered. So I have one question. For beginners, what would you like to say? Like there's a post-traumatic endophthalmitis is there, there's a foreign body inside. What are the basic tools that they need in their OT to tackle any case like this? What is that you suggest them for somebody who's starting new, of new surgeon?
Could you repeat, please? I didn't hear your question. Could you repeat?
So my question is, the new retinal surgeon just finished the fellowship, started a private practice, encountering this is the very first case they are facing in their practice. So what are the basic tools For them to handle a foreign body removal, what are the basic tools that you suggest them to have in their OT setup for them to remove any foreign body?
Okay.
And when you
For
suggest an anterior approach and when you suggest a sclerotomy approach. Anterior
okay.
approach, I mean via Collins scale tunnel, and the other one is making a sclerotomy directly with that MBR plate.
Okay, I think for thank you for your question first, but I think for dealing with the trauma cases and intraocular foreign body, the first thing to have is to suspect intraocular foreign body, because not every cases is the diagnosis of intraocular foreign body might be difficult in some cases. So we have to suspect it with examination and history, taking history of the patient. This is the first thing. The second thing is to have a preoperative examination and evaluation and to of the prognosis of the patient, and to have consentment of the patient. The third, when decide to go for surgery, it's of course we have to have a plan for our surgery. So we have to have different plan for different situation. In case of intraocular foreign body without endophthalmites, the early vitrectomy is the option, because we have to go for surgery to avoid any complication, PVR and retinal detachment and endophthalmitis. But in case of endophthalmitis established, as in our case, I think we can opt for treating the patient with injection, intravitreal antibiotics, then waiting for improvement of the anterior chamber visualization and improvement control of inflammation to have better condition for surgery. And I think for via surgeon who have no experience with such cases, we have to have some multidisciplinary approach, or who have another colleague specialized in trauma cases.
Thank you. Over to the other panels for discussion. Anybody has any questions?
Thank you for the lecture, Dr. Nesreen.
Thank you.
Do you routinely leave antibiotic depots in the vitreous space when you close up the surgery? For example, if the intraocular foreign body is a suspected could be a nidus for possible infection, do you end up leaving intraocular antibiotics?
Yeah. If there is a suspicion of intraocular foreign body or infection, I end my surgery with injection of antibiotics.
Do you usually use is it moxifloxacin, or what's your routine antibiotic?
Vancomycin and ceftazidime.
Vaco and Cefta. Okay. Thank you, doctor.
Thank you.
Any other questions from any of the panel? So if not, I'll hand over the thing to Dr. Renuka to introduce the next speaker. Thank you, Dr. Nestin. Wonderful talk.
Good evening, everyone. I'm Dr. Renuka Sapre. I would like to thank Dr. Vaibhav Sethi for this opportunity. And it's my honor to introduce Dr. Mohammad Moghzi Mahboob. He's a distinguished ophthalmologist and renowned expert, vitreoretinal expert from Egypt. He's the professor of ophthalmology at Ain Shams University in Cairo, where he has established himself as a leading authority in retinal diseases and vitreoretinal surgery. He holds an MD and PhD in ophthalmology and is a fellow of Royal College of Surgeons from Edinburgh. His international training credentials are exemplary, having completed fellowships at Oakland University and Wayne State University in Michigan, USA, as well as specialized training with the Associated Retina Consultants in Michigan. He is currently serving as a consultant vitreoretinal surgeon at El Watani Eye Hospital in Cairo. He holds significant leadership positions in ophthalmology community. He is the head of scientific committee of Egyptian Vitreoretinal Society and serves as a board member of the prestigious organization. He is also EVRS ambassador for the European Vitreoretinal Society. He's actively engaged in medical education and international collaboration, having participated in over 30 international conferences. And he has contributed significantly in the field through numerous international publications in medical and surgical retina, including recent research in artificial intelligence applications in retina care. It is my great pleasure to welcome Dr. Mohammad Mohabi. Welcome, sir.
Thank you very much for the introduction. I'd like to thank Vivihop for his gracious invitation to be among this elite group of surgeons. I'll share my screen now. Okay, so I'm going to talk about some tips and tricks for not your everyday penetrating ocular trauma cases. We know that visibility is a key issue in those cases, and this is such an example of such a case with a huge intraocular foreign body. And you can see here the cornea is edematous, and you have a large corneal wound in the middle. And you would say, well, I need keratoprosthesis in those patients. You would be surprised that just adding some glycerine to these corneas is enough, and you don't need to do keratoprosthesis or remove the cornea and put it back. And this is the same surgery at the end under air, and you can still see a good visibility. The cushioning and the lining, what I like to call, I mean, we always chase after removing the whole vitreous in those cases before removing the intraocular foreign body. And I actually find that this cushion of organized vitreous hemorrhage can be cushioning enough for the underlying retina while dealing with such huge intraocular foreign bodies to avoid the contact of the foreign body with the underlying retina, as well as using of the viscoelastic. And I found that using cohesive viscoelastic is better than dispersive viscoelastic. You can push the foreign body away from the macula. At the same time, you can cushion the macula if at all it falls. The previous idea of using PFCL to do that have proved failure, because the PFCL cannot withstand the weight of most of those intraocular foreign bodies. Another really interesting thing or tip in that scenario is the methods and facts of the ultrasonography. So this is such an example. This is a patient penetrating ocular trauma, and you can see here that in the echography report, it says no intraocular foreign body detected. However, the sonographer didn't care to just have a look on the slit lamp. You can see an entry point, so there must be a foreign body inside this patient, and in fact, I found it. This is the other side of the coin. So this is a patient, again, penetrating trauma with an intraocular foreign body, and the sonographer was very accurate, saying it's in the nasal quadrant, about 30 millimeters from the optic disc. So I went into the eye, and I couldn't find any foreign body, okay? And then I said, if the ultrasound says there's a foreign body, there must be a foreign body. So what I did was indentation at the nasal quadrant, and actually found an intraocular foreign body under the peripheral retina. This was kind of a surprise to me, because it is large enough to be detected by the sonography, but it was not in the posterior part of the eye to be seen if you go in. And it can be easily left if you didn't follow the gut of the sonographer that there is something inside the eye. So in all cases, rely on your examination rather than on just the ultrasound. The way in, this is sometimes needed because some of those cases we have, like this case, we have an evidence of annular ciliocoroidal detachment and suprachoroidal hemorrhage. So the usual route through the pars plana might be difficult. And so I decided not to try and just to use the infusion cannula inside the anterior chamber all through the surgery. This is a case of lensectomy, vitrectomy. You can see here it's a tough case with incarcerated retina, and you can work the whole thing with the infusion cannula inside the anterior chamber without the need to use a pars plana cannula. And this is while removing the incarcerated retina, and this is under PFCL, of course, and this is at the end of the surgery doing the silicone oil PF cell exchange, and the silicone oil also was injected from the anterior chamber maintainer or anterior chamber infusion cannula. The way out, so this is then another way of seeing things when you are having an intraocular foreign body that is not regular, like in such a case. Again, a case of penetrating trauma, clearing the way out. This is already the lens is ruptured, like you see here, and this is just residual lens matter. And you can see here the leathery vitreous from the vitreous hemorrhage, and a very, very irregular, sharp foreign body. And I think if you try to remove this foreign body through the sclera, you will be damaging a lot of uveal tissue. So in that case, I use the anterior chamber at the way out. In my opinion, I believe that the cornea is more forgiving. You can change the cornea, but you cannot replace the ciliary body. And you can see here, it's very irregular foreign body, very large, very sharp, and it would have taken a very large wound in the sclera to remove it. So I think this is one way of doing things, taking it out. This is a similar case with a smaller foreign body. And again, this patient is aphakic. Again, sharp foreign body, metallic foreign body. And again, I'm using the iris as a shelf to remove the foreign body outside of the eye instead of enlarging the scleral tunnel or the scleral opening. Orientation is also important when dealing with intraocular foreign bodies. So again, this is a patient with two small foreign bodies in supratemporal quadrants. And I found that ultrasound here was a little bit mistaken because it was a large nail, actually, not two foreign bodies. It was one large, huge intraocular foreign body. You can see the head of the nail. And this one has to be oriented properly. You cannot take, of course, this one from the anterior chamber. You need to take it out from the sclera. But you need to orient it inside the eye first to direct it outside through the sclera. It was really huge. Bimanual maneuvers sometimes also needed with irregular shaped foreign bodies, like this one. This is a needle. This has to be, held with one hand and then grasped with the other hand. Here I used again the cornea to get this irregular foreign body out, handing it. Handshake technique, as they say. The Swiss knife concept, which means that you have to have everything ready. This is a large wood foreign body, and I've tried with every available foreign body forceps I have until I couldn't use except the toothed scleral forceps to get it out, because it needs something to, get plunged into the wood itself to take it out. A tip for the future, and this is something I'm really interested in, which is choriectomy using the diathermy in cases of large areas of exposed RPE. And this really in that specific case, prevented reproliferation post-operatively. And I was even thinking of using this technique in cases of giant retinal tears to prevent proliferation. The most important tip is expect the unexpected and be ready to improvise. If I can share one case, a 23-year-old male patient, a blunt trauma following a motor car accident, repaired rupture globe 1 week before presentation. The visual acuity was light perception. AC showed total hyphema. This is his ultrasonography, and you can see here the ultrasound itself, because of the hemorrhage, I couldn't see the retina myself on the sonogram. However, the report said retinal detachment and choroidal detachment. So I tried in that case to go the regular way. I need to clear the anterior chamber first from the hemorrhage, and then I tried to go into the vitreous cavity using the pars plana routes. I was wrong because I couldn't see the tip of the cannula, so I had to change and again go through the anterior chamber. Go through the anterior chamber, of course, after doing a lensectomy. Sorry. Yeah, I didn't open it. And you can see here when I put the first cannula, it was in the suprachoroidal space because I can see this brownish blood. So I tried to take out as much as I can from the suprachoroidal hemorrhage. And then I went in, I put one of the infusion cannula in the anterior chamber because again I couldn't see the tip of my cannula in the pars plana, and I continued the whole surgery this way. And this is what I'm talking about. This is why I brought this case, because this case, when I was going in at first, I thought, well, retinal detachment, choroidal detachment, something that we see every day. But I was surprised to find this closed funnel retinal detachment with partly incarcerated retina. With a lot of subretinal hemorrhage. And you can see here now it's clearing up, and you can see the area of incarcerated retina. I'm trying to remove as much as possible of the subretinal blood and subretinal bands if I can. This actually was 1 week after the repair of the rupture globe. And I used a small bubble of PFC here. I know that maybe it's not the time yet, but I use a small bubble just to be able to go and remove the incarceration or free the retina at the site of incarceration. After doing that, the PFCL was removed, and I started dealing with the underlying retina, because I found that the retina is not flat enough. So I removed the PFCL and went again under the retina, and I tried to remove as much as possible of those membranes that now became visible as the visibility improved after removing most of the blood. Trying to take out as much as possible of those subretinal bands and subretinal membranes. See here, a lot of membranes. Then I went again and injected PFCL. And the laser, and this is how the patient looked like at 1 month and 2 months post-operatively. The retina is in place. The vision did not improve much, counting fingers at 50 centimeters, and the pressure is low. I don't know when or should I ever remove the silicone oil in this patient. However, these are the cases that's unexpected, and you have to, you're inside the eye, you found a closed funnel detachment. You won't just leave it and say it's hopeless. This is what you're facing. So with that case, I end my presentation, and thank you very much.
Thank you, Doctor, for your very interesting talk. There were really amazing videos and very interesting cases. And thank you for the great tips from your talk. I just have one question. In your most of the cases, you've based your surgery depending on the ultrasonography. So do you usually advise CT scan for all your patients, or your investigation of choice is USG?
Yes, of course, we do a CT scan. That's, I mean, this is medical legally required even, okay? But the ultrasound gives me an idea about what's going on inside the eye. It allows me to consult the patient better because, sometimes I tell my sonographer, it's better to tell me that the patient has RD and I don't find it than you telling me there is no RD and I go inside and find an RD, because the patient then will blame me for it. So I'm not basing my decision on just the ultrasound, but I think the ultrasound is an important tool, but also the sonographer is more important than the ultrasound itself in guiding you. It's just a guide. I always tell the patient ultrasound is like holding a candle in a dark room. So you say, maybe here there is a window, maybe there is a door, but nothing is sure until we go inside the eye.
Yes, definitely.
Can I ask a question?
Sure.
Dr. Gini.
Hi, how are you? Hi,
Good,
Mohammed. Fantastic presentation, incredible cases as usual. Congratulations. From your vast experience, you mentioned a chorioretinectomy to prevent proliferation. And that is something we learned in the last few years. Have you tried amniotic membrane as well?
No, I haven't had the chance to do that. I know there is also I think the bovine ones that Barbara is using. I think some of them, and I've seen amazing videos from Barbara, but I have never had the chance to use it. No.
Oh.
Do you have experience with it?
Yes, we did one case with that. It's early days, and I can't really say what the results would be, but it seems to be doing well. So it could be an option because sometimes, obviously, chorioretinectomy is impossible because it's so close to the macula that you can't do it. So that would be, I think, an option to patching up with amniotic membrane to prevent proliferation. But congratulations, beautiful videos as usual.
Thank you very much. Thank you.
I would like to, if there are any other questions from the other panelists.
Yeah, I just wanted to ask that in how many of these cases the cornea actually forgave, and how many cases there was a need to change the cornea?
Well, those are young patients. All of them are very young patients with 21 very good. Hours. Excuse me. Sorry. With very good endothelium. So up to 5 years, 6 years follow-up, I haven't seen a decompensated cornea yet, but I'm sure some of them will decompensate along the years as they grow older.
Okay. Are there any other questions from the panelists? Okay. Thank you so much, doctor, for your great talk. I would like to request Dr. Bhavik to start the next session.
So, hello, yeah, dear colleagues and professors. I'm Dr. Gökçen from Turkey. We are now moving on to session 4, extreme retinal topics, and our next speaker is Dr. Gianpaolo Gini. It's a pleasure and honor to me to present him, an esteemed consultant surgeon from Sussex, who's currently the president of EVRS and liaison officer in Europe for American Society of Retina Specialists and board member and scientific advisor for the Italian Association of Ophthalmologists. Professor, we are excited to hear your talk.
I'm pleased and honored to be in this great meeting. My thanks go to SETI and the whole team that made this possible. It's really an incredible event. Yes, so I want to share my screen with you. I'm not very good with these things. I hope I can do that. Can you see my, yeah, can you see my video? Can you see my, sorry,
Yes, Doctor.
screen? All right. Try to get this out of the way. Oops. Okay. Right. Okay, good. So, so today's actually the presentation deals with the surgical approach to retinal detachment, which is secondary to retinal vascular tumors. Now, retinal vascular tumors are not particularly frequent or rare entities, but they can lead to severe visual impairment in about 50% of all cases due to a number of adverse events, particularly through the formation of cystoid macular edema, heart exudates, and ultimately these can lead to macular fibrosis. But not only, there are also retinal detachment associated with these cases. So obviously, where we have situations in which visual acuity is at risk, we have to intervene with some sort of treatment. And unfortunately, there's no consensus on the ideal treatment for retinal vasoproliferative tumors at present. There's a plethora of options available, which go from laser photocoagulation to PDT to brachytherapy, anti-VEGF, and cryotherapy. I think that especially for large tumors, the most common and widespread use of treatment is cryotherapy. And this is based essentially on a triple freeze thaw technique. So you freeze the tumor all the way to the apex of the lesion. You allow to defrost, you freeze again, and you repeat this 3 times. Now, this is quite an effective treatment, especially for, as I said before, large tumors, but it can lead to complications. And this is what we'll be talking about today. So we present a case of a 67-year-old woman who came to our attention for bilateral deterioration in visual acuity associated with bilateral macular edema, which was more significant in the left eye. And you can see that a fundus examination revealed the presence of retinal vasoproliferative tumors in both eyes, the one in the left being more severely affected, with the tumors occupying most of the temporal periphery with an extension about 160 degrees. The procedure that we carried out at this stage, because of the danger to the visual acuity, was the triple freeze thaw technique. Because of the size of the tumors themselves, we figured that that laser therapy would not be effective because there was too much tissue to treat. So we proceeded with freezing with the operation on February 1st, 2024, and we ended the procedure with a subtenon triamcinolone injection to dampen the inflammatory reaction which we knew would occur. And this is an Optus scan of the eye on February 21st. So we're looking at 3 weeks after the procedure. And you can see that we start having some fluid buildup, which is encroaching on the macula. The exudates have reabsorbed, and you can see that the lesions have shrunk in size and in extension. So the treatment has been effective, but we do have this unwanted buildup of subretinal fluid. A week after, we see that there is progression of the subretinal fluid going into the macula itself. On the other slide, you can see a better image of the bilaterality of the tumors. You can see the small tumors are present in the right eye as well. So now we have to decide what to do with this condition, and obviously the patient was given another sub-tenon's injection. Started off on oral corticosteroids in addition to the topical ones that she was having. Despite all this, the progression continues, and we therefore introduce an Ozurdex implant to dampen this condition while awaiting to proceed to surgery. Surgery which takes place and to fix the retinal detachment which has occurred. We make the patient obviously pseudophakic it to allow better visualization of the fundus. You see that the Ozurdex is still present. We will remove this during the procedure. We search for peripheral breaks. We do not find them, and we proceed with a drainage retinotomy, which is successful in actually flattening most of the retina, but not all of the retina completely, supporting our idea that this is not only an exudative detachment, but also a tractional one with retina shortening. So the approach obviously becomes that of performing peripheral retinotomy, which is carried out temporarily 180 degrees to allow for the retina to fall back to its more congenial space, and we proceed to remove the tumors which were now inactive. Now you can see that there is no bleeding here, fortunately, because the freezing of the tumors has been effective and efficient. So there is no bleeding. Obviously, you have to be careful because there is reduced visibility due to all the tissue that is being freed with the vitrectomy. You have to be careful not to damage the underlying choroid, otherwise you would have obviously hemorrhage, which you want to avoid. So this is very simple steps which proceed to the complete elimination of the tumor masses with indentation, as you can see, and then we simply proceed to applying peripheral carbon to flatten out the retina, and obviously endolaser and silicone oil. And you can see that there has been a considerable retraction of a few millimeters of this edge of the retina, so confirming the fact that this is not only an exudative detachment, but obviously a tractional one as well due to retina shrinking. So the patient maintains an attached retina 3 months after the procedure took place, as you can see from these Optus scans taken in April and in June. And then you can see that now 20 months down the line, yes, 20 months, roughly almost 2 years after the procedure, the retina remains attached, and after having removed silicone oil, and the vision is surprisingly good, I would say, at 0.4 Snellen. So this is the case. Now, the other eye, which has smaller tumors, will be treated differently. Obviously, we will be using photocoagulation in that eye and not cryotherapy. So what have we learned from this case? Well, we have, as I said, these tumors are not very frequent, fortunately. So our experience is not a huge one. We've only had a few cases, but I can say that cryotherapy is effective in eliminating even large retinal vascular tumors, but you must expect an intense inflammatory reaction, which is probably proportional to the amount of tissue which is treated. And this reaction must be prevented as best as possible, either with anti-VEGF before the surgery, Ozurdex at the end of the procedure, or a combination of both. So my final consideration would be regarding the surgery itself. If a retinectomy was, and this is open for discussion with the panel, with the audience, with the other esteemed colleagues, whether the best option was, as I performed, a retinectomy, or perhaps one should have thought about a buckle before proceeding to a retinectomy. The difference being obviously that with a buckle you reduce you can actually reduce the amount of inflammatory response which you have following the retinectomy itself. I thank you, and I would like to invite you all to our 22nd EVRS meeting, which will be in Cancun, Mexico, from the 12th to 15th of November of this year. It will be an outstanding event because the program is really, really good. Go online and check it out. We have outstanding speakers, and as usual, we will have the EVRS spirit, which is now known throughout the world for its friendship and for its warm cordiality. Thank you.
Thank you very much, Dr. Ginny, for sharing your valuable experience on this highly specialized topic. I want to learn one thing according to your experiences. Do you always choose cryotherapy for relatively large tumors initially, or is there a threshold for tumor size that you go for tumor excision and restricted retinectomy just before cryo?
I do not have a cutoff, so I can't tell you just ideally. I would like to tell you when I have a certain thickness of the tumors, then I intervene in one way or the other. I cannot tell you that. My experience does not cover that. But for intermediate, these were very large and extensive tumors. For something smaller than this, obviously, I would go for photocoagulation, which has to be repeated in several steps because you do not just get the effect in one single session. So it really depends from the size, but I would say if you feel that the photocoagulation can penetrate the tissue deeply enough, then go for that. But if they're very thick tumors, such as these were, then you need to go with cryotherapy.
Thank you very much. Thank you. And do you have any experience with baltuzifan for von Hippel-Lindau-related retinal capillary hemangiomas?
No.
Okay. Thank you very much. Is there any other questions from panelists or audience?
Either was very clear or Or was very boring?
It was very neat. Thank you very much.
Sorry, may I make a question?
Yes, Hussein, please.
Hi, Gianpaolo. I mean, a great case as always. I mean, I had a similar case back in the UK, and it was an inferior vasoproliferative tumor, but I was not as lucky not to have PVR reretinal detachments, even under oil. And I'm just thinking why one case would behave differently. Perhaps I think when I look at your case, I think you managed it in phases and you started with the cryotherapy. And I'm not sure if starting with the cryo, freezing that retina, the vascular supply, and then going to vitrectomy to deal with it, perhaps this is where things change and you end up, having less of a PVR. But because what I did was I did the cryotherapy as part of the vitrectomy, um, because there was like less of a subretinal fluid when I went to do the vitrectomy. But I believe that your approach is much better. That you dealt with it in phases. You managed most of the fluid and most of the activity first, and then you went to the vitrectomy. But after having put the cryo in place, any sort of feedback from your side on this, Gianpaolo?
I think I was forced to do what I did. It wasn't really planned. So I wasn't hoping to go into vitrectomy. I was hoping to actually get away with just freezing, but it didn't work out that way. So with the benefit of hindsight is should I have done laser? Some people argue you should have done laser. I believe that because there was so much tissue there, laser would not have been effective. Then you have to consider that these patients need to be lasered with with relatively high or long treatment time because obviously you have to use relatively low power but long exposure. So it's painful, and
Yeah.
to reduce the pain, you have to obviously give them peribulbar blocks or whatever, subtenos or whatever, and that requires more procedures because you will not get away with simply one laser session. You have to do several laser sessions. So cryo in this case, to answer and Gochen's question again, I think cryo here was probably the right, it was this decision which seemed right because there was so much tissue and you did not want to go through several sessions of photocoagulation. What happened after was maybe predictable, but obviously one did not want that to happen. What the fact that we use freezing obviously allowed for the lesions to shrink and the blood vessels to close, and you have to allow for time to that to happen, so you will not get bleeding. But it also created, I believe, the shrinking of the retina because you had traction. So there was internal shrinkage of the retina itself, shortening of the retina itself. What might have made a difference with PVR not developing is the fact that so much effort was put into dampening the inflammatory reaction. So we started with posterior subtenons, triamcinolone. After the procedure had finished, we repeated that. We gave oral steroids. We actually went in and put Ozurdex. So that's why I stress the fact that if you're going to be treating these cases, you have to start off preventing the inflammatory response. So anti-VEGF before you treat, either with cryo or with laser, and to the extreme that if you're doing surgery, then you want to end your surgery with at least, I think, either repeat or anti-VEGF or even an Ozurdex implant, because your real challenge here is preventing the inflammatory response that the cryotherapy will induce. Does that answer?
I see.
a great answer. John, one question, Gianpaolo. The case I had, can you hear me?
Yes.
Yes. So the case I had, I remember, it was like a vasoproliferative tumor in a case of hyperparathyroidism. So when I went into the subretinal space to get that vasoproliferative tumor, under the cutter, for me, it felt like I'm crushing stones. Now, how did it feel under the cutter in this case, in your case?
It was soft.
It was soft.
It was soft.
I see. I see. Because I was like, the diagnosis of a vasoproliferative was confirmed, but it felt like maybe because of the hyperparathyroid, status, it felt like, calcified rather than softish.
Yeah,
So,
soft.
interesting. Many thanks, Gianpaolo, for such a great case. Thank you.
Great question. Thank you.
Dr. Gianpaolo.
So
Yes.
is it sorry for the interruption, but I think we can move on to the next presentation because already we
okay.
are short on time.
Sorry.
By all
I
means.
think
just asked in the
Dr.
chat.
Bhavik
Sorry.
has joined and he can introduce the next speaker, Professor Danilo. Dr. Bhavik?
Yeah, hello?
Yes, we
Yes,
are able
Dr.
to
Amit.
hear you.
Yes. So I just joined. I was because it was delayed. Yeah. So are we having Dr. Danilo's talk now?
Yes.
Okay. Just a moment. Right. So first of all, thanks to Pan Ophthalmologica and ADH and Dr. Vaibhav Sethi for this wonderful platform. Our next speaker, Dr. Danilo Heneta, is a wonderful surgeon, and his training includes medical school in Quilla, and afterwards residency in ophthalmology was also in Rome. He is one of topmost Italian surgeons, and during his residency, he spent 1 year as a research fellow in New York at Weill Cornell Medical College, and under the supervision of Professor Amico. Then he improved his training in Amsterdam with a fellowship in surgical retina, and last part of his training consisted of 3 years in Liverpool, firstly in medical retina and UADS fellowship, and then high volume surgical retina fellowship. Since 2019, he is working in Italy as a veterinary consultant. And if you look at his main interests are complex vitreoretinal surgery, trauma, and the last part which I liked about is bioengineering. So without taking more time, we go ahead with Dr. Daniel's talk.
Dr. Danilo, can you unmute yourself? We are not able to hear you.
Sorry. Oh, sorry about
Yeah.
that. Sorry.
Yeah.
So, well, first of all, I'd like to thank all the committee for this kind invitation and great presentation. I think I don't deserve all this attention, but I'm really grateful. I'm surrounded by beautiful moderators and speakers. So I'm going straight to the point, and I'm going to start my presentation. So I need to share my screen, and give me 1 second because I need to find out actually. Yep, here it is. So give me 1 second. Yeah. Okay. So I think you should be able now to see my screen. I'll start from the beginning.
Yes, we can see your screen.
Yeah, give me 1 second. Okay. So my topic is closed funnel retinal detachment, tips and tricks. So, as we all know here, we don't have a classification, a standard classification for PVR. So we have mainly 3 different classifications. The first one was started by Bob McNamara, and then we went through other 2 different classifications. But if we focus on funnel retinal detachment, we are always in the bottom lines, which means according to the one by Robert McNamara and Ronald Michaels, what we are focusing on are the most advanced retinal detachment. So we are talking about total retinal detachment involving all the quadrants with an advanced step of PVR. And moreover, we have what we usually find as a napkin ring. So approaching to this kind of retinal detachment is always a kind of complex because you need to pre-plan everything from the beginning, knowing that your surgery can last hours, and moreover, you need a lot of armamentarium. So the first approach is selecting the proper gauge. I think at this moment of our technology, we can start definitely going forward a 25 gauge. Usually, I prefer to use between 25 and 23 gauge. I usually don't use 27 because maybe I need vertical scissors and curved scissors, and usually you don't have them in 27 gauge. Usually you have three different kind of forceps, at least on my table. You have an ILM forceps, maxi grip forceps, which are the best ones, in my opinion, to manage PVR. You can use, of course, also crocodile, so serrated jaws. And then usually I use also vertical scissors to usually delaminate the peripheral vitreous. The dye is fundamental. Most of the time, if you don't have a proper dyeing during the surgery under BSS, you should use and convert under air. And moreover, one of the most adjuvants that we've been using since Stanley Chang from Columbia University in the early 80s developed and patented it was the perfluorocarbon. So PFCL has helped a lot our surgeries and our surgical plan since we are able to have a kind of counter pressure while we are doing the peeling. But of course, we know also that perfluorocarbon is mainly toxic if it goes under the retina. So one of the things that you have to do usually is, at least what I usually do, is don't use PFCL at the beginning of the surgery. What I usually do at the beginning is viscoelastic dissection. So Pepe Garcia Rumi from Barcelona and also myself, we published two recent papers using the viscodissection technique in order to push downward the retina and moreover to visco-stretch the retinal adherences. So I think the best way to discuss about PVR advanced cases and final retinal detachment is presenting 4 videos. So I'll be very quick and I will go straight to the point in order to focus on 4 videos. This is a failed buckle, and this is what the patient came after 4 weeks losing her follow-up. So as you can see here, this is a closed final retinal detachment. In this case, I'm using a 23 gauge, and what I usually do is you need to have a very ordered fashion. So what I usually do is an outward, inward technique, and then I do the upside way around. So what I usually do is I trim and cut all the anterior vitreous, removing all the anterior hyaloid, and then I start a bimanual technique in order to remove all the PVR, which is starting from the beginning. So what you need to do is cleaning up the funnel and then lifting up the hyaloid, the remaining hyaloid, as much as you can. Here, as you can see, I put the chandelier on, and then what I'm going to do is dyeing, because dyeing is fundamental. And what you will observe is that I always change different forceps according to what I need in that time. So if I really need to peel a little bit, then I can use an ILM forceps. But then if I need something like a very hold and strong grasping, then in that case, a crocodile or a maxi grip are the best ones. Only in this case, when I'm able to see the optic nerve head and the posterior pole, then only in that case, I put the perfluorocarbon. A proper shaving is mandatory. You can see here inferiorly where was the previous break with the buckle, and then of course an inadvertent break has been made also by me. I mean, iatrogenic break are pretty much a reasonable attended in cases like this. Then a proper shaving, fluid exchange, 360 degrees of laser, which is not mandatory, but usually I think it's necessary. And then silicone oil, of course, in cases like this, I think it's very difficult to tamponade this with air or gas. This is another case which has been done recently. This is a patient who came with a total cataract, 360 degrees synechia, seclusio pupillaris, and moreover a closed funnel. So this is after the cataract what we expected. Also in this case, what you see is exactly the same approach. So you see the anterior hyaloid, which is perfectly contracted and clearly visible, and it's usually your step to start with. So you need to clear all the Berger space and all the retrolenticular space, and then you need to clean up and move from the up above down to the bottom. Once you've cleaned up everything, a proper shaving in order to enlighten all the superior part of the retina, all the anterior part of the retina is mandatory. And this is a very important step. I'm going to block this. So what you need to see here is that the retina is folded. If you remember the picture which I showed before, this is the last stage. It's like, it seems like the retina is broken here, but it's only folded inward. So you need to be very careful here, because if you made a break here, you think that it's already a broken retina, but actually it's not. It's just folded inward. Then the basis of the vitreous here is clearly visible, and what you have to do is lift up as much as you can. And now you will also see my use usually of the vertical scissors, which I use it as a kind of spatula, and can be a sharp spatula or a smooth spatula according to my needs in that time. In this case, I'm using it as a kind of hook, as like you can see here, and it's pretty much clear. It's pretty much visible, the posterior attach of the vitreous base. And here, what I'm going to do is a bimanual technique in order to cut as much as I can all the remnants part of the vitreous debris over the attachment of the vitreous base. And here, exactly now, what you will see later on, once I will put the perfluorocarbon, is that the retina will come back in place. So once I've used to lift up as much as I can, then in that case, using a maxi grip, then I lift up as much as I can the vitreous base, and then I put the perfluorocarbon. I use a dye also in a case like this, and then you need to peel. I mean, in PVR late stage, you need to peel a lot. So don't get stressed, because the more you peel, the more you will find the membrane to be peeled. So, and I gradually lift up the perfluorocarbon as much as I can. I never lift up in a blind fashion. I need to see where the perfluorocarbon is reaching and which kind of level am I reaching. Then I mark the break here. I put the laser, and then I do fluid exchange. This is the check after 1 week after surgery, and the patient now is doing pretty much well. This is the third case. This is a patient with a trauma. He was lost for follow-up, previous corneal trauma, and then he had the PK and FACO-IOL. In a case like this, I already knew that this case was going to happen with a retinectomy, because I think this was one of the most advanced one, where you cannot clearly see that the funnel is pretty much closed. And you can clearly see here that without the chandelier, you cannot proceed. And then now with the forceps, what you do is a blunt and sharp dissection. And it's clearly that what you have to do is cleaning up the most anterior part of the retina and then going downwards. You cannot do the other way around, because you'll never be able to clean up the posterior pole without creating space anteriorly. Another thing that you have to do is always pulling the PVR from the posterior part to the anterior part, and never the other way around, because what you're going to risk is always to cause a kind of dialysis. And then you're going to create any other trouble. Once you've cleaned up as much vitreous as you can, in this case, I was moving in a very tangential fashion, and you cannot pull only the retina, so you need to move with two instruments. So bimanual technique in my idea is mandatory here. Then I knew that I was starting doing a 360 degrees retinectomy, and because I had also subretinal PVR, which is now you'll see is pretty much massive. So once I removed all the PVR of the subretinal space, I left also some perfluorocarbon on the posterior pole, because what I don't want is to cause inadvertent rotation, and then you're going to cause an inadvertent macular translocation. Once I did this, I trimmed all the anterior part of the retina, and then laser. And in this case, I did a direct PFCL silicone oil exchange. What you don't want is going under air, because the risk of slippage in a 360 degrees is pretty much concrete. Last but not least, this is another case, and it's my last case, and it's a patient where he was performed surgery previously for PK. Then after trauma, he had an expulsive hemorrhage, so he expelled also the IOL and partially vitreous. and he was referred to our clinic. So there was a von Gundersen flap, which I removed. Then he had also a suprachoroidal hemorrhage. I isolated the muscle. I removed the previous PK, and then at 8 millimeters, I started draining the suprachoroidal hemorrhage. It was, I think, 10 days to 12 weeks after surgery. Then you can see the retina here. You cannot place any kind of trocar. And even with the Thanos scraper, you cannot remove it. So what I did is what we do in pediatric surgery. So I did, through a limbal approach, I injected viscoelastic. And the viscoelastic is going to posteriorize the retina. Once you do that, at 3 millimeters from the limbus, what you do is you start gradually opening the funnel, which is not very aggressive in terms of PVR, but you need to be very careful because all the hyaloid is there, and removing the hyaloid is not so easy sometimes because you need to be very careful, otherwise you're going to break the retina easily. Once I did that, only in that case where I could see the posterior pole and the optic nerve head, and there was no break so posterior to the equator, then I put the perfluorocarbon. I removed, in that case, there was some nasal previous retina from a previous break. And then after that, what I did is lifting up the level of perfluorocarbon, shaving with what we call like a kind of sandwich technique. So you have perfluorocarbon on one side and vitreous on the other side, and the laser in this case. And then I performed the PK, removing the key pro, and then the Eckhart, actually not the key pro. And then after that, I did the fluid exchange directly. And this is the results after 2 weeks after surgery. And of course, there is a low tamponade effect because, of course, all the choroidals were drained. So which are my conclusions? When you have a case like this, exhaustive pre-retinal and subretinal PVR is necessary. I would say it's mandatory. Retinectomy only after removing all the pre-retinal membranes, as much peripheral as you can. Chandelier, dyes and PFCL will be your best friends, also viscoelastics actually. There is always a space for an encircling band. It's not my primary choice, but I think it can be useful. I didn't put it here, but ILM peeling, I think it's mandatory. Sometimes I don't do it because I know that I will do it after I will remove the oil, but I think you can do it also intraoperatively with the first surgery. Silicone oil is your tamponade, and be calm because you'll need time, a lot of time. So thank you very much for your attention. I hope this will be very interesting. And remember that progress comes from doing the unconventional, as Bob McMahon taught us. Thank you so much.
Yes, wonderful, wonderful surgeries, Dr. Danilo. So much
Thank
to
you.
learn from them. A few questions to you. I want to ask you a question like,
Yeah.
do you consider removing all the membranes at one stage, or there are occasions where you feel like, okay, I have done enough and I may cause more problems to the patient, so let us leave it for the second surgery? Does that
Sorry,
happen?
I'm trying to, yeah, sorry, go ahead. Sorry.
Yeah. So my first question to you is that, do you aim, obviously we aim for removing all the membranes, or all the folds to be like relieved, but at times there are certain membranes which are too thick, okay, and that is causing a retinal fold. So do you think that at the second surgery, should we go and intervene and preserve how much of our retina is left out?
So, well, first of all, thank you for your question.
Yeah.
You know, of course, you have to peel as much as you can, but we know perfectly that we have three different kind of PVR. So subretinal and pre-retinal, I think, so the pre-retinal is mandatory. You need to remove as much as you can. Subretinal only if it's sight-threatening. So if it's approaching the posterior pole, if it's disturbing the profile of the fovea, or if it's having a kind of tent effect, which is not flattening the retina. Retina, I think the retina needs to be treated as a brain tissue. So you need to preserve as much as you can. So, and when you are going to approach a funnel detachment, you know that it will take not only one surgery, at least two surgery. But our main goal is giving this eye the chance to see something. So I totally agree with you. If you don't have time, if you don't have a good approach in the first surgery to peel everything, or you think that they need to be mature a little bit, this is also why you are putting oil, because oil gives you the time to sieve the posterior pole. And if then you have to peel, if you have to peel after, even in 1 month, 1.5 months, you go in. Steve Charles has published several videos, and he's not the only one, where he's doing the peeling under oil. You can be happy about that. You cannot be happy about that. I usually don't do that.
Okay.
But what you can do is bringing the patient back, you remove the oil, you peel the remaining part, or you refine your first surgery, and then you can put oil again if you need it, or you can put long-lasting gas like C3F8. We don't have to forget that this kind of detachments are very complex and they really are demanding for not only one surgery. So you need to be patient. So I totally agree with you. Give yourself time.
Yeah. The second question is when you spoke about you showed us certain cases as well. So when you do a 3-stage retinectomy, sometimes there is no membrane underneath the retina, but there's this talk which is there of the retina, and because of the memory of the retina, you are doing a 3-stage retinectomy and it just turns. So the macular translocation. So even for example, I have tried and I have left certain tissues, say 4 corners, have not removed them to ensure, but somehow
Exactly.
the talk comes in. So how do you manage the talk?
Well, that's a good question, and it's not very easy. No, I think I can give you some my tips and tricks, but I think that every surgeon it's always can always deal with this kind of turning retina. So what I usually do is I proceed gradually doing the cut as you already said. So I don't do always at 360 degrees immediately. And I keep always perfluorocarbon not very close to my retinectomy edge, a little bit more posterior. And I try to keep as much as I can as myself safe. So I cut a little bit, then I see how it works. I cut a little bit more, I see how it works. I usually try to cut the more shrinked part. So I usually don't cut like inadvertently everywhere. I usually cut the most shrinked part where I think it's more intraretinal contraction. Because once I did that, I know that the other part will stay like the same. Of course, if you have a kind of rotation, then I mean you can try a little bit to put
Yeah.
it in place, but you know better than me that we are just
Even
humans. So you will never
true.
be able to
Yeah.
to put it in place
So
exactly.
sometimes you can
Rukja,
give
mera hai
radial
abhi.
cuts. Sometimes you can give radial cuts. So any tips to
Yes.
give how to give radial cuts so that you don't go towards the optic nerve and you are somewhere where so the torque component is compromised in a way.
So I think radial cuts are perfectly reasonable. I think radial cuts are it's one of the technique that you can do. I've done
Sure.
them couple of
Right.
times. I mean, I didn't show the videos where I did it. I
Yeah.
do them a couple of times. I've done it. Um, I I usually tend not to, I mean, it's an idea maybe, but I usually don't like to go
True.
posterior to the equator to do this kind of cut just because, it's an idea. But I've done them and they work. They work
Yeah.
because what you see when you do a radial cut is like the retina, it's exactly
Right.
perfectly in place, it's opening, and then it stays like that. And our goal is always preserving as much vision as you can. So instead of maybe giving him a very bad wide anisoconia, if you have this cut but the posterior pole is perfectly in place, maybe the patient will feel better. So I think, I mean, I totally agree with your approach. It's perfectly reasonable.
True. Yes. Maybe the last question in the interest of time. Sometimes we do PFCL and silicon oil sandwich technique because that helps for the superior and the inferior retina as well. Your comments or your thoughts on that?
I don't do it.
Okay.
Either I use a light silicone oil or I use a heavy silicone oil.
Okay.
I don't do combined endotamponade usually. But usually with the light silicone oil, you are fine with that. I mean, usually in my case. And moreover, I decide light silicone oil or heavy silicone oil according to where I think it will redetach. Because we need to be honest. It can
True.
happen that it can redetach.
Right.
So if I know that it will redetach mainly superiorly, then I want to be sure that the inferior part is okay. So I can put a heavy silicone oil like Denzron Extra, and then I will remove it and it will be fine. So, but I usually don't do combined endotamponates.
Thank you so much. It was wonderful discussing with you. Thank you, Dr.
Oh,
Daniel.
pleasure. My
Yeah.
pleasure. Thank you very much.
Over to you, Dr.
Thank you, Bhavik, and thank you, Dr. Danilo. So some
Thank
of
you.
the cases which you had shown, the results are just unbelievable. Really superb cases.
Oh, thank you. Thank you very much.
So now it is my pleasure to introduce Dr. Hassan Motara. So he is a veterinary consultant at Cairo University. He earned his master's degree in ophthalmology in 1981, and later he had the pleasure of working with Dr. Payman in 1986. He is a board member of the Egyptian Ophthalmology Society, also the Egypt Vitreoretinal Society, and also the European Vitreoretinal Society. So over to you, Dr. Murtaza, for your presentation.
Okay. Thank you for the introduction. Just give me a second to.
So while Professor Mortada is preparing his presentation, I'd like just to say something, which for me was an honor to take part of this meeting, and moreover to make my presentation before Professor Mortada, which he knows is one of my closest friends and one of the best surgeons I've ever seen doing his surgery. So I want just to say this, to take some time to take this chance. Sorry about that.
Thank you so much. Thank you, but I need your help in sharing my screen. Okay, and now share windows, share this window. Oh, well, okay, Danilo, can you stop sharing your screen? Danilo, can you stop sharing your screen?
Hassan, tell me again. Sorry, I was just a little bit out.
Can you stop sharing your screen?
Oh,
stop
I
sharing.
thought I stopped.
Probably not.
Hello, Dr. Hassan sir?
Yes.
No, I'm not sharing it, it says.
Dr. Hassan sir, you shared your screen. Firstly, I stopped share now. Now click on share button at the bottom side, a green color button. Then a window will pop up. Then double click on first option, that is screen, or click on share.
Okay.
What you can see in front of you, sir?
Sto morendo, cazzo.
I can see pen ophthalmo 2. That's what I can see. Share.
Yes, yes. We can see your screen perfectly coming, sir. Sir, open your PPT, sir. We can see, sir. We can see, sir. Go ahead, sir. Thank you. Sir, you shared your Now open your PPT. You stop share. Again,
Now
share
stop
screen.
share.
Yeah, you stop share now. Now go to share screen once again. Click on share, double click on first option under the entire screen.
I'm sorry. Okay.
You shared, but you stopped share once again.
Okay.
Yeah, click on share button. A window will pop up. Yeah, you did, sir. You did click on exit. Sir, you directly clicking on the PPT. Please don't click directly on the PPT.
Can you see it now? Can you see it
it
now?
is showing. No. We are not able to see, sir. Again, stop share, click on share screen, then click on first option under the entire screen. Sir, click on that, click on exit full screen.
Okay.
Yeah. Now
Allow
click
to
on
share
button.
window. Allow to
Yeah.
share screen. Allow to
Yes.
share screen.
Yes, yes.
So I got this.
Yeah, open your PPT. Yeah. Yes. Yes, sir.
Can you
Perfectly
see it
coming your
now?
slides.
Excuse
Yes,
me?
sir. Yes, sir. Yes, sir. Yes, sir. Please go ahead,
Okay.
sir. We can see.
Okay. I apologize for this delay, but I think I should thank the organizer of the PEN Ophthalmologica for the opportunity of inviting me to this wonderful meeting and to share and listen to this wonderful discussion. My talk is about long-term outcome of relaxing retinotomies and retinectomies in complex PVR cases. Well, as you all know, PVR is the most common cause of failure following surgery, and it accounts for 5 to 10% of the failures. And the objective of this presentation is to investigate indications, techniques, long-term outcome, reoperation, and complications of extensive relaxing retinotomies in PVR cases. This is the surgical strategy. I do not like to operate under silicone oil. So in recurrent cases, I usually remove the silicone oil first. I start by managing the anterior segment, including reconstruction of the anterior segment, management, and this is followed by management of the posterior PVR, removing epiretinal membrane, extended ILM peeling, and then the posterior retina is reattached with perfluorocarbon liquid injection. And then management of the anterior PVR follows, doing basal vitreous gel shaving, epiretinal membranes dissection, then planning the location and the extent of retinotomy, complete retinal reattachment, endolaser, direct perfluorocarbon silicone exchange, and methotrexate injection in complicated cases, but no scleral buckle is used. This is the steps I follow for the management of the anterior PVR. So the posterior retina is stabilized with perfluorocarbon liquid, excision of contracted basal vitreous gel, peeling of epiretinal membranes, retinotomy and retinectomy of peripheral contracted retina, removal of subretinal proliferation when interfering with retinal reattachment, reattachment of the retina completely with perfluorocarbon, and endolaser. This is the steps and the rules for doing a retinotomy. It should be done at right angle to traction, radial extension to the ora serrata, as peripheral as possible, but posterior to any contracted tissue or breaks, heavy diathermy, high cutting rate, minimal vacuum, starts in the mobile retina and ends in mobile retina, overdoing better than underdoing. Small radial cuts may be needed, excision of peripheral contracted retina, hemostasis, and avoid trauma to the choroid. Well, let's start with this simple case of a recurrent detachment. You can see multiple star-shaped folds with dragging on the retina, inducing multiple peripheral retinal breaks. I started by stabilizing the posterior retina with few cc of perfluorocarbon liquid and then removing the epiretinal membranes. I start the retinotomy at the ora serrata and then doing the heavy diathermy circumferentially in order to delineate the site, the location of the retinotomy, and also to stop any bleeding. Watch how to cut the retina. The probe is not touching the choroid or the retina. It is just aspirating the peripheral retina. This is how we do the radial cuts, and then you may extend the retinotomy to the ora serrata on either side, and is completed by examining the subretinal space, looking for any subretinal proliferation. More perfluorocarbon liquid is injected, and then endolaser, and finally direct silicone oil exchange, keeping the fluid needle at the edge of the retinotomy to receive any fluid coming from the periphery. This is another case in a pediatric retina. First shaving the peripheral retina, and then you can see that the peripheral retina is full of retinal breaks. Actually, this is a patient with the Stickler syndrome that underwent previous laser treatment that weakened the peripheral retina. So I have to perform a retinotomy in order to relieve the traction. And you can notice the presence of a central retinal tears, which is characteristic of Stickler syndrome. This is how to deal with the peripheral proliferation, doing scleral indentation under chandelier light. Here I'm using the green filter or color channel on the Ingenuity machine, which enhances the visibility of the peripheral vitreous and also reduces the glare to the surgeon eye and enhances the visibility of both the epiretinal proliferation and the vitreous. And then this is another way of doing the retinotomy, is to apply aspiration to the peripheral retina and then by tearing the retina instead of cutting. A case of a recurrent retinal detachment with multiple star-shaped folds. After managing the posterior PVR and stabilizing the posterior retina with perfluorocarbon, I start to deal with the peripheral epiretinal proliferation, which were strongly adherent to the underlying retina. The direction of peeling is not always from posterior to anterior, because you can manipulate the epiretinal membrane in different directions until you and allow also some time for the retina to relax until you get it away from the retina. This is how to deal with anterior PVR. You can see remnant of the vitreous that was not removed in the primary surgery and removing it, but this cannot be done without doing a retinotomy because of the retinal shortening noticed. Notice how the green filter enhances the visibility. And this is the way how to do the retinotomy without cutting, just tearing along the line of heavy diaphragm. Then subretinal proliferation can managed at the same time. This is the use of two forceps, two serrated forceps, in order to get the extensive subretinal proliferation working bimanually, flattening the retina, applying endolaser, and then direct perfluorocarbon silicone exchange. This is the case of a multiple peripheral large retinal tears, and I call this as a project of a giant retinal break that was not completed because the contraction of the peripheral vitreous stopped at this stage. So diathermy is applied. You cannot buckle this case because if you try to buckle this case, you are going to apply heavy cryo applications, and this may induce by itself severe PVR in addition to the presence of these multiple breaks. So 360 retinotomy in order to remove all the traction at the periphery of the retina, with the retina stabilized with the perfluorocarbon. The 360 retinotomy was completed, and the retina was attached by more complete filling with perfluorocarbon liquid and endolaser, and then direct perfluorocarbon silicone exchange. So this study included 447 eyes suffering from retinal detachment complicated with severe PVR. The age ranged between 6 and 67. The retinotomy, the extent was ranged between 120 to 360, and there was a primary PVR, recurrent PVR, pediatric PVR, or traumatic PVR. Complete reattachment following silicone oil removal was achieved in 92.8%. Improved best corrected visual acuity was achieved in 72%. Hypotony was always an expected complication in these recurrent cases, and it occurred in 12%. Recurrent proliferation at the edge of the retinotomy was encountered in 25.8%. These are some of the cases. This is the preoperative and the postoperative pictures. The retina is stable. There is no activity or proliferation at the retinotomy site. This is another case of a closed funnel with the retina completely stable. This is the preoperative and the postoperative pictures. Again, the scar is stable and not active. Another case. This is how the proliferation at the edge of the retinotomy looks like, but this can be managed at the time of silicone oil removal, just peeling the proliferation at the retinotomy site and trying to complete peeling without tearing the retina. You may apply more laser to complete the procedure. This is to show the hypotony in this case of a closed funnel PVR and a giant retinal break. Again, in a child, the time should be spent peeling the epiretinal membranes, here working from posterior to anterior, and trying to mobilize the retina. Here I started from the periphery to the center, and then perfluorocarbon is injected, and more epiretinal membranes were removed. The blue dye was injected again under the perfluorocarbon to complete the extended eye lamp peeling, which I tried to peel as much peripheral as possible, because in this way you also remove epiretinal membranes and the cortical vitreous, then moving to the periphery, trying to shave the vitreous base. You can notice that the pars plana epithelium here was detached, then managing the rolled edge of the associated giant retinal break, complete the filling, managing more proliferation at the periphery, and completing the 360 retinotomy, then filling the eye completely with perfluorocarbon liquid and doing endolaser. And I inject methotrexate in this case. This is epimacular proliferation occurring, but you can deal with this easily during the silicone oil removal. Peeling it, although I removed the internal limiting membrane, but some proliferation occurred in spite of this, and this occurs rarely. And then the retina is stable. This is the preoperative with the proliferation and postoperative. Extensive retinotomies and the macula is healthy. These two pictures show how the extended peeling of the internal limiting membrane can protect the macula from proliferation in the postoperative period. So in conclusion, extensive relaxing retinotomies, retinectomies, is a well-established technique and can improve the anatomical and functional outcome in eyes with advanced degrees of anterior PVR. The extent of the retinotomy has no relation to the final visual acuity, contrary to what was mentioned in the past literature. Hypotony is always a threat. Primary extended eye lamp peeling can protect the posterior pole from recurrent proliferation. I encourage and urge you to use methotrexate because it reduces the incidence and severity of recurrent proliferation, and retinectomy should only be performed if less aggressive measures are not sufficient. And thank you.
Excellent presentation and cases, Dr. Hassan Mota. So I had a few questions. So regarding the PVR which you had mentioned, so most of these cases after doing the retinectomy, they do really well at 2 weeks. But when they come for a follow-up after a month or after 2 months, usually again the PVR sets in, and the area where we have done a retinectomy, those edges try to roll up again, and they again lead to a redetachment. So for managing these PVRs, you had mentioned in the conclusion use of methotrexate. So I have started to use methotrexate just recently, around 6 months back, and I have got excellent results. But I wanted to know how do you use methotrexate in your practice? Do you inject directly in the irrigating solution or do you inject intravitreal?
I started using methotrexate now since 2 years. And I noticed really it decreases the incidence of recurrent proliferation. It is not a miracle and it's not the solution. It is not the final solution, but it definitely decreases the rate of reproliferation. The first injection is done at the end of the surgery under the silicone oil. And then depending on the severity of the case, I inject after 2 weeks, again, under the silicone oil. And of course, I release some of the silicone oil. And sometimes I inject 2 more injections if the condition is severe, like cases of penetrating trauma in pediatric PVR. So these cases need more injection. The concept of putting the methotrexate on the infusion fluid, I'm not pro of this idea, because what you inject inside the eye is washed and it is removed during the operation. But you need to leave methotrexate inside the eye, and it has to be repeated, especially in difficult cases, because PVR is an ongoing process. And the concentration, finally, the concentration I'm using is 400 microgram per 0.05 mil. And it is prepared by the anesthesiologist, and we have a paper in the OR to describe how to dilute the methotrexate to suit the intraocular injection.
Okay, so the second question was, how do you manage subretinal PFCL bubbles? Because many of these retinectomies have a risk of PFCL slipping under the retina. So at what post-op day you try to again go in and manage them?
Very good question, of course. And I do not stop the infusion, but what I do is that you keep the infusion fluid not perpendicular to the surface of the perfluorocarbon, because this disturbs the perfluorocarbon and initiate the formation of bubbles. But try to tilt it and make the infusion to come tangential to the surface of the PFCL bubble. And also during the indentation, I do indentation for myself, try to indent gently. And then when you release the indentation, try to release it also gently while keeping the instrument in the cannula, because this decreases the turbulence of the fluid inside the eye. If it happens, then one of the bubbles slipped under the retina. If it is peripheral, then try to manipulate it with the soft Thanos scraper, and you may succeed in having it to come out through the edge of the retinotomy, or if not, and then try to aspirate it with a 41 gauge cannula. And the same if it is if it's posterior, then try to aspirate it with the 41 gauge cannula used for the subretinal injection.
One last question, doctor. So, do you believe in two-step surgery for such PVR cases? Means in the first case, in the first surgery, you inject PFCL, keep the PFCL for a week or 10 days, and later on, then again go in and exchange it with oil.
No, I tried all my techniques and my best effort and all my efforts to have all things done in the primary surgery. So do not delay anything for the future, except, as Daniello said, if sometimes the membranes are immature and they are very difficult to peel. And only in these cases you may go inside the eye again to peel the membranes when they are mature. I don't know whether methotrexate help in this issue or not, but I do not like to use a double tamponade. I do not use heavy silicone oil. I use regular silicone oil, 2000 centistoke, to be removed when the retina is stable after 3 months, except when there is hypotony. I'm usually reluctant to remove the silicone oil. So I think when you perform the surgery as neat as possible, removing all the membranes, removing the eye lamp, what I call extended eye lamp peeling. And in trauma cases, I usually do a chorioretinectomy, reattach the retina, remove the anterior flap of any retinotomy or a giant break, inject methotrexate, which I believe is helpful in these cases. Then the rate of reoperation will be less. But I use only a regular silicone oil, no perfluorocarbon liquid tamponade, even with the ART or whatever.
Thank you so much, Dr. Mortaza. We can
Thank you.
take one last question from the panel if anyone wants.
I wanted to ask, sir, in myopic, do you do iLM peeling in all the patients of these PVR changes? And what about myopics? Like there already the iLM staining is very less. So do you peel in that also?
Yes.
Any tips for that?
Yes. I'm not pro of doing buckling of the macula in myopic traction maculopathy. I usually do eye lamp surgery, fovea sparing eye lamp surgery or eye lamp peeling for myopic foveoschisis, and multi-layer flap for myopic macular hole with or without retinal detachment. So what I know the next question will be the difficulty of reaching the posterior pole, but you can displace the site of the sclerotomy posteriorly, and you can go as far posterior as 6 millimeters from the limbus. And by doing this, the regular instruments will enable you to reach the posterior pole. I think it needs good blue dye, and it needs maybe augmentation by repeated injection of the dye.
Thank you, sir.
Thank you.
Thank you so much. So I think we'll move to the next and the last presentation of the session, and Dr. Pooja can take over.
Thank you to all the speakers and the moderators for staying with us until the last talk. I thank Dr. Vaibhav and Pan Ophthalmologica to give me this opportunity. It's an honor to introduce our next speaker, Dr. Yi Ting Shea. I apologize for any mispronunciation, sir, on my behalf. Dr. Shea is a clinical associate professor at the National Taiwan University Hospital, Taipei, Taiwan, having completed his retina fellowship at the National University Hospital and a research fellowship at the Duke Eye Center, USA. He is a faculty at the National University Hospital, Taiwan for over 10 years now, with close to 200 publications and various talks and complex surgeries to his credit. Dr. Shea is also a member of the Wei Li Shen's research lab at the University Hospital. Today, Dr. Shea will be walking us through his work related to complex retinal detachments in cases of chorioretinal colobomas. Over to you, sir.
Okay. Thank you, Pooja. You just pronounced it wonderful. So it's my honor to Yeah, it's my honor to have a talk here. Here and thank you for everyone to be here until the last minute for the last talk today. And let me share my screen. Okay, can you see the screen? Okay. Okay, I'm going to talk about the use of amniotic membrane graft for choroidal glaucoma complicated with retinal detachment. Okay, this we just have just heard so many wonderful talks today, and I just want to share one simple case, but I think it is interesting to share. This is a 6-year-old girl who had blurred vision progressing for 2 months in her left eye. He already had the history of amblyopia. So he's under the atropine treatment and patching for the right eye to treat the amblyopia of the left eye. But the vision dropped from 0.5 to 0.01 in recent 2 months. So she visited my clinic and we found that actually she had coloboma not only in the iris but in the fundus, the choroidal glaucoma in both eyes. But it is more severe in the left eye. And when she visited me, she already developed the retinal detachment of the left eye. So in this case, I performed vitrectomy with PVD induction and ICG-assisted iron peeling of the macula. And because the break is within the area of the choroidal glaucoma, so it is difficult. It is not possible to do the laser to fix the break. So I used the amniotic membrane, wet preserved amniotic membrane to tuck the break and plus intravitreal silicone oil. This is what I do. What I did during the surgery. I found the break and used amniotic membrane, which is much larger than the break. And after the operation, this is the 2 weeks after the operation. You can see that the blue line is the area of the break, and the red line is the area of the amniotic membrane. The break is well covered by the amniotic membrane. And 2 months later, the retina seems attached 2 weeks after the operation and seems attached 2 months later, but still with some shallow retinal fluid in the inferior area. And we can see that the amniotic membrane began to shrink at this moment, but it still covered the hole. It seemed to cover the hole well in this situation. So although I see some residual subretinal fluid in the inferior part, I decided to observe. And this is the OCT. The OCT seems like the hole. The hole is, I'm not sure if it is well covered by the amniotic membrane. It seems not well covered, but from the color finder, it seems it is totally covered by the amniotic membrane. So at this moment, I decided to observe to see if the residual subretinal fluid will be resolved. However, the 6 months late after the operation, the subretinal fluid persists and even operates a little bit. So I think it is for sure that there should be some unsealed break even under the intravitreal silicone oil. So I decided to do the second operation. So now the problem is how can I find? I'm not sure if I can find the break. So in this second operation, I used the Brilliant Blue G, the PPG, to see if I can see the break. The first use of the BBG, I try to see if it can dye something, some residual membrane there, so I can peel maybe some residual epiretinal membrane, or if it is possible to dye some internal limiting membrane, so I can peel it, or even use the ILM to tuck the break. However, during the first use of BBG, I cannot see something special. So, but when I try to remove the BBG, it seems that there is some break. You can see that here is the residual amnion. It stay well there, and it is not. There is no open break here, but I seem to find some open break in another place. I cannot be very sure at that time. Okay, so I decided to dye with the BBG for the second time. This time I not only want to dye some residual membrane, but during the first dyeing, I cannot see any membrane. But at this time, I try to see if I can inject the BBG and let it flow into the subretinal space, and I can see the break more clearly. That's why I chose BBG this time instead of ICG, because if I use ICG, although it is better to dye the membrane, it will result in more retinal toxicity. So I use BBG this time. So you can see that during the removal of the BBG, we can see that actually some BBG have went into the subretinal place. So when I try to remove the BBG, I can identify where the break is. Here is where the break is. Because it is within the area of choroidal globomas, and retinal detachment is very shallow. So it will be difficult to identify where the break is if we didn't use the dye for the contrast, not only for the contrast, but to let the dye go into the subretinal space, so you can see where the dye came out when you remove the dye. Yeah, that's the way I try to see the break, and also to examine if there is any other break. And during the procedure, I found that this is the only break I can see. So it should be the only break. Okay, so after that, after I identified the break, I try to use an even bigger, even larger amniotic membrane to cover the break. And the original break, the original amniotic membrane stay well in the places, although it shrunk to only a small pieces. So this time I decided to use even larger to cover the break. The break is not very large, but I use a much larger amniotic membrane and try to cover the whole area. And I try to because it will shrink, so I'm afraid that during the shrinkage it will tear the original break, which is covered by the original amniotic membrane. So I try to cover the amniotic membrane across the original one. This is what I try to do. Okay. So after the operation, we can see that, well, 1 month later, the amniotic membrane, as I predicted, it shrank a little bit, but it seems still quite well and cover the break. Although it doesn't really cover the red line. The area of the red line is the original amniotic membrane, and the area of the yellow line is the amniotic membrane used during the second operation. It didn't well cover the original one, but at least it will cover the break, and the retina seems well attached 1 month after the second operation. And this is 2 months after the operation, and this 5 months after operation. We can see that the amniotic membrane keep shrinking during as time goes by, but and this is at 5 months. This is after the silicone oil removal. I didn't want to remove the silicone oil so early, but because of the migration of the silicone oil to the anterior chamber and subsequent cataract, so I have to do the cataract surgery as long as remove the silicone oil. And after the silicone oil removal, the retina seems well attached, so I did not re-inject the silicone oil. So this is the condition after the silicone oil removal and the retina stay well attached. But however, we can see that the amniotic membrane shrink. I hope it will not keep shrinking. So, but at least 5 months after the operation, it seems quite well. So I just want to share with you the experience of using the dye such as BBG to identify, not only identify the epiretinal membrane, internal limit membrane, but sometimes it is useful to identify the retinal breaks within the area of chorioretinal glaucoma. And amniotic membrane is good to tuck or cover. And the second time, actually, I use a bigger one, a much bigger one, to cover the break within the chorioretinal glaucoma. And we should use a bigger piece because it will shrink later after the operation. So thank you.
Thank you, Dr. Shea. Wonderful surgery, wonderful outcomes. A few questions. Did you have any difficulty while you were trying to place the amniotic membrane graft?
Yes, because we want to use a large piece of the amniotic membrane, so we cannot use the trocar. You have to remove the trocar and even enlarge the sclerotomy up to such as the size of a 20 gauge. So you can put in a large piece of amniotic membrane. And in this case, I think it will be easier to use a wet preserved one instead of the dry preserved one. So that's what I use, a wet preserved amniotic membrane through a big sclerotomy.
As far as I can see, post 5 to 6 months after your surgery, the graft is slightly shrinking, but not resorbed as such. Do you have any experience about that? Because some surgeons have mentioned about graft resorption after a few months of surgery. So does that play a role in the eventual outcomes or possible redetachments?
Yes. I not only in I have also used the amniotic membrane in a large retinal break, large posterior retinal break for the case of retinal detachment. And in that case, in my experience, the amniotic membrane shrank after the operation, but it is not totally resolved. There is still some residual amniotic membrane there to cover the break or even tuck the hole. So I'm not sure about, maybe I'd like to hear the experience from other speakers. In my experience, the amniotic membrane never just disappear. It will shrink and will contract, but still some amniotic membrane will be there. I'm not sure if it is the original amniotic membrane or it is some glial tissue, but in my experience, there is always something like the mixture of amniotic membrane or glial tissue there.
Any questions from any of the other speakers or moderators?
Yes. So excellent presentation, doctor. So I had one question. When we try to place that amniotic membrane under PFCL over the retina, that amniotic membrane just gets rolled around the forceps or the light pipe which we are using, or even in the bimanual technique, means we are not able to just put it over the retina. So any tips how to do it?
Yeah, it just as you mentioned, it is difficult. But in this case, I didn't use the bimanual. I mean, I didn't use the chandelier light, so I just used the light pipe to help manipulating the amniotic membrane. I think the key point is if you use a big one, a large one, and it will it is easy for a big piece of amniotic membrane to stay at the surface of retina first, then you can begin to manipulate. And in this case, I think it doesn't really matter which surface is there, but I think that I tried during the procedure. I think if you find the amniotic membrane adhere to the retina more easily, then it should be the correct side. But I think I didn't intend to use just I mean both sides will do for me, and I just try to make it stay in the right place. I think a bigger one is easier to manipulate, even it is not totally open. At least it will cover. If it is big enough, it is not totally open. It will still cover the area perfectly.
Doctor, when you said you would tuck the amniotic membrane, that would mean would you just overlay it on the break or tuck it all around under the edges of the break?
During the first operation, I put it over the break and try to insert a little bit into the hole. But because it is much bigger, much larger than the hole, so a lot of membrane still cover the surrounding area of the hole. But during the second one, I didn't really try to tuck. I just cover it. I think the coverage should be good enough in this situation. So if you really tuck the total piece inside, it will. I think it is not good to cover the hole after the shrinkage of the amniotic membrane. So coverage might with a large piece might be a better choice.
Thank you for answering all those questions. Any other questions from any speakers or panelists? All right. If not, then I think we can wind this up. Thank you for all the excellent talks and past midnight in Taiwan, I guess. Thank you for staying with us. Dr. Vaibhav, if you're there, would you want to add any closing points?
Yes, I like to put into appreciation the beautiful presentations, the lovely discussion, and the whole flow of all the presenters and taking our time all over the world, 44 countries. We're still going on and discussing it late at night. This just shows the passion and the excitement that we all put into and the effort that we put in. And thank you very much, everyone, for taking your time from your operation theaters, from your outpatient departments, from your family and from your friends, and coming over and giving these presentations and moderating these sessions. Thank you very, very much.
Thank you.
Thank you.
Thank you.
Thank you, Vaibhav.
Thank you.
Thank you.
Good morning, good evening, and good night.
Thank you so much.